We are together. All three of us are together on same computer. We are joined already. We have joined already. Jhansi has joined. We are using the same computer. Yeah. All three of us are using the same computer.
Morning, sir. Good morning, Dr. Gupta, sir.
Yeah, Dr. Ramesh, sir, very good morning. Thank you for joining.
It's our pleasure, sir.
Yes, sir.
Is my voice audible?
Yeah, audible, sir. Can you listen my voice, sir?
Yeah.
Yeah, I'm just waiting for our speakers from ESI Medical College to join, sir.
Sure, please.
Okay.
बिलीव ज़्यादा मेरे तो मेरे दुआ दिल से चुप आकर तो चुप ना फिर
A warm good morning to all the dignitaries, national and international delegates. Myself, Dr. Archana, Assistant Professor, Department of Pharmacy Practice, Pulla Reddy Institute of Pharmacy. Welcome you all to the national webinar on innovations in pharmaceutical innovation.
Viper sir, Ramesh. మన క్వశ్చన్స్ అడిగింది కదా ఇప్పుడు దాకా ఆయన ఓపెన్ ఉండే ఇప్పుడే ఆయన స్విచ్ ఆఫ్ చేసి
Organized by Pulla Reddy Institute of Pharmacy in association with ESIC Medical College and Hospital and IPA Narsapur branch. We are organizing this webinar as we are celebrating Pharmacovigilance Week from 17th September to 23rd September in association with National Coordination Center and Indian Pharmacopoeia Commission. The theme of this year's Pharmacovigilance Week is Pharmacovigilance, a step towards patient safety. Now I welcome one of the speakers, Dr. P. Karuna Sri, MD, Department of Pharmacology, ESIC Medical College and Hospital. Welcome, ma'am. It's a great pleasure to welcome another speaker, Dr. Mehdli Ali Mirza, Assistant Professor, ESIC Medical College and Hospital. Welcome, sir. It's a great opportunity to welcome another speaker of today's webinar, Dr. U. Jhansi Rani, from PharmD, Patient Safety Pharmacovigilance Associate, ESIC Medical College and Hospital. Hello, ma'am. Now I welcome this webinar, Dr. V. Ramohan Gupta, Principal, Pulla Reddy Institute of Pharmacy. Welcome, sir. Now I welcome co-convener of this webinar, Dr. D.K. Suresh, Professor and Head, Department of Pharmacy Practice. Welcome, sir. Now it's very honorable to welcome Dr. Ramesh Alluri, President of IPA Narsapur branch, and also the Principal of Vishnu Institute of Pharmaceutical Education and Research. Welcome, sir. Now there will be a lamp lighting ceremony and invocation song. I request all the delegates to mute their mics. I request all the delegates, please
No.
Now I request Dr. CHDP, Assistant Professor, Department of Pharmacy Practice, to introduce the speaker. Now I request conveners of today's function, Dr. V. Ramohan Gupta, Principal, to welcome the dignitaries.
Hello. Hello. Yeah, a very good morning to all. Indeed, it's a pleasure for me as a convener to invite all delegates to this wonderful virtual national webinar. It's indeed heartening to see such a tremendous response of delegates from all the states of our country. And we have received few registrations from the other countries as well. Really, we initiated this webinar with an intent to reach a few states across India, but we have seen a tremendous response, and it's amazing to witness the registrations as delegates from all corners of India and from some other countries as well, like Nigeria, Sri Lanka, Saudi Arabia, and we have few registrations from China and Thailand as well. It's indeed very happy to me as a convener, having seen such a tremendous response from the delegates for registering and sending the e-posters to this national webinar. At the outset, on behalf of Pulla Institute of Pharmacy and on behalf of ESIC Medical College and Hospital and Indian Pharmaceutical Association Narsapur branch, I welcome all the delegates to this webinar, and very thankful for you all for registering and sending the e-posters to this webinar. Indeed, it is tremendous to announce that we have got around 1,000 delegates registered to this webinar, and around 250 delegates, they had sent their e-posters on this theme of Pharmacovigilance week. I'm sure all the delegates will be really happy after attending this webinar and will definitely gain some information and knowledge out of this, because we have eminent speakers from ESIC Medical College and Hospitals who are going to talk about the theme of the Pharmacovigilance week, that is a step towards patient safety. Indeed, I request all the delegates who have joined to this webinar today to just look at the theme of this Pharmacovigilance week, that is a step towards patient safety. What I advise to all the student delegates who are in this national webinar is to make or create awareness among the masses. I want you to reach out to the masses and make them awareness about what ADR is all about, that is adverse drug reaction is all about, and where to report those adverse reactions, when to report, and to whom to report, what is the procedure to be followed. So especially I advise this to all the pharmacy students who are in this webinar, and especially the PharmD students who are going to hospital wardrooms for their clinical training, to reach out to the masses and to make them awareness about this adverse drug reaction reporting, and let us put a step forward in achieving the patient safety. So it's a time for me to welcome our eminent speakers from ESIC Medical College and Hospital, Dr. Karun Shri and Dr. Rajarani and Dr. Ali Mirza to this webinar. I profoundly thank them for having given their consent to attend this seminar and to deliver the keynote speech. And they are very passionate and shown their interest to disseminate the knowledge and information to the delegates who are participating in this webinar. I also take this opportunity to welcome Dr. Ramesh, the Indian Pharmaceutical Association President, Narsapur local branch, and other office bearers of Narsapur local branch, Indian Pharmaceutical Association, and for attending this webinar. Of course, this has been done in association with IPA local branch. And a special information that I would like to give you all the delegates on this occasion about the Indian Pharmaceutical Association local branch in Narsapur. That is, this IPA Narsapur branch has received the Special Appreciation Award from the IPA head office, IPA Mumbai, for the activities that are being continuously conducted under this banner. And I really wish the IPA local branch of Narsapur will get so many such awards and laurels in the near future under the able presidentship of Dr. Ramesh. I also welcome the faculty of Polarity Institute of Pharmacy and the faculty from other institutions as well. Coming back to this theme, that is, we are in between we are in the middle of this Pharmacovigilance week, my dear delegates. As you all know, the theme of this Pharmacovigilance week is a step towards patient safety. So the aim of this is to make the public and healthcare professionals aware about the importance of ADR reporting. It is all to achieve to improve the patient safety by and large. So from this platform, I once again request all the delegates to reach out to the masses in your community, and especially the students of pharmacy and PharmD students, to initiate the awareness among the patient community in the hospitals, wherever you are participating in the ward rounds. All this we are doing is for the patient safety. Also, I wish to inform all the delegates is that our institute, Polarity Institute of Pharmacy, has applied to Indian Pharmaceutical Commission for recognizing our institute as a center for reporting adverse drug reactions. And we are looking forward for the positive reply from the Indian Pharmaceutical Commission as far as this recognition is concerned. I really appreciate our management for giving us continuous support to carry out all such events without any hindrance at all. And very importantly, the tremendous teamwork shown by Dr. Suresh DK, HOD of Pharmacy Practice Department, and his team. And in fact, we have got the supporting hands and extended by the other faculty of Polarity Institute of Pharmacy. I just want to mention few names here: Dr. Ravindra, Dr. Swapna, Mr. Imaduddin. All have contributed to their own for bringing out this national webinar online across all the delegates. I just now leave it to the speakers to just continue this program. I can ask the organizing committee to initiate the next event. And lastly, I wish all the delegates the pleasant further 2 to 3 hours of this national webinar. I really assure as a convener of this national webinar that you will end up or you will leave the Zoom meeting happily gaining some information, important information and knowledge. Thank you one and all. All the best once again. Thank you. Yeah, I can ask the organizing committee to initiate the next event of the program. Thank you.
Thank you, sir. Now I request Dr. Ramesh Alluri, IPA President, to speak a few words on this occasion.
Okay, thank you. Because it was unable to unmute myself. I think thank you, Dr. Archana. And first, I would like to convey my special thanks to all the distinguished key speakers who have taken their valuable time, despite their busy schedules, in enriching our delegates on the latest updates during this pharmacovigilance awareness program. Secondly, I would like to thank Dr. Gupta, who is the Vice President of IPA local branch. And with the support of him, we are also the partners, and the achievement of the best outstanding award for us is all because of your support. And we wish that Pulla Reddy College continues to do many more of such programs to create more awareness in the public. However, due to these unprecedented times, and I believe that we are unable to meet personally the deliberations. However, one way it is good that we are able to gather people not only from India, but from abroad also to participate in these programs. And I just want to share one thing to all the delegates. I don't know whether you are aware or not, that the most searched word during this pandemic time in Google is none other than clinical trials. So I think everyone is very curious to know what it is actually. So it has opened a new arena for us, and it has strengthened and given us an opportunity to do something beyond. And it's time for us to update ourselves by participating in such seminars, because until you update yourself with the current knowledge, I strongly believe we cannot go further, or we'll be one step back. A best example include today, Alembic is going to announce a new drug which is going to be launched, right, or it is going to say its results to the press. And being knowledgeable, let me quote my own example. I invested a 5-digit figure in the shares today morning. And definitely I'm going to get the outcome out of it by evening itself. So why I'm saying this example is always being updated with the current knowledge can give you more of knowledge and the confidence that you can go beyond the rest of the crowd. So I urge all the participants to stick on to this meeting and enrich yourself with the current knowledge which is going to be shared by various distinguished speakers. So finally, I would like to say that everyone should have this personal revolution to enrich ourselves with the current knowledge and prevent ourselves from copying with others, as everyone has their individual question paper. With these few words, I thank you all and wish and advance Dasara vacation. Thank you. Sign out. Over to you, Dr. Archana. Thank you.
Thank you, Ramesh sir. Sorry for the inconvenience due to technical issues. We got delayed few minutes. Now I request Dr. C.H. Deepthi, Assistant Professor, Pulla, Department of Pharmacy Practice, to introduce the speaker, Dr. Karuna Sri, to all the delegates.
Yeah, good morning, everyone. Myself, Dr. Deepthi, Assistant Professor in Polarity Institute of Pharmacy. Now, I would like to introduce today's speaker, Dr. P. Karunasri, Associate Professor, Department of Pharmacology, ESI, Medical College and Hospital. Madam has done her MBBS from Gandhi Medical College 2005 and MD Pharmacology from Gandhi Medical College, Secunderabad. She has other qualifications like Masters in Medicine, that is Diploma in Family Medicine from MGR University, Tamil Nadu. She had fellowship in advanced courses in medical education. She has done certificate courses in thyroid disorders from Public Health Foundation of India in 2016. Madam has worked as coordinator in reporting adverse events. She has guided 6 projects in research platform and also guiding 12 projects. She had published more than 20 publications in national and international journals. Madam has participated and organized workshops and seminars. And Madam has 11 years of experience in teaching medical students and pharmacy students and nursing students also. Madam is a member of different institutional committees like Institutions Ethics Committee and Scientific Advisory Committee, and also a coordinator of Pharmacovigilance Committee and Medical Education Unit. Now, I would request our speaker, ma'am, Dr. P. Karunasri, madam, to start the session.
Very good morning to all of you. Am I audible? You are not audible now. Yep. Thank you very much. Thank you, madam. And I thank the Polarity College of Pharmacy for giving us this opportunity to speak on this event in this especially this National Pharmacovigilance Week. And I'm very happy to share hands with your college and your being here on their project work as well as doing the clerkship. And according to today's topic on the medication errors, shall I share my screen?
Yes, ma'am.
Yeah. Yeah. Is it? I hope it's visible to you.
Yes, ma'am.
Yeah. So in today's topic, my session is on the medication error. So as madam has introduced me, myself Dr. Karunesh from ESSC Medical College, Hyderabad. So I'm going to speak about the today's session under the contents like what is this medication error basically, and a few terms and definitions pertaining to these medication errors, and what are the various types of medication errors, what are the factors causing them, and the impact of this medication error, and what initiatives have been taken by the WHO and others, and the summary. So as we know that to err is human. So every human being is make mistakes in their life. There won't be any perfect human who won't be doing any mistake, isn't it? So pertaining to the medication safety, if we relate this human error to the medication safety, so what may happen? So even the studies had revealed that the negligence caused by the humans, that is wantedly making the mistakes, is very less. But there are mistakes that may happen during the process of the various or the process flow, when during the various means of prescribing or the dispensing or the administration of these medicines. So what may happen when these errors occur? And what we need to do, the important thing is to learn from our mistakes, as we know. So so in today's topic, what we have to learn is not only correcting ourselves or join hands in decreasing the medication errors, but also how to decrease our errors by making some standard formats or standard procedures in the hospital setting. As we know, commonly we do not want to know about anything unless we know about the importance of the subject. Similarly, here the medication errors, when we talk it, everyone thinks why we need to know about the medication errors, isn't it? So why we need to know about it? If you see the burden of these medication errors, what is happening when the errors are happening? When errors occur either in the administration side or in the hospitals or the outpatient side, wherever it may be, it nearly costs 42 billion US dollars per annum because of these medication errors. It's a very huge cost. And moreover, these medication errors are higher in the low income groups compared to that of the high income countries. And the patients or the people who are taking these medicines, if you see their disability adjusted life years, it is very, very reduced in the low income groups compared to the high income countries. And the prevalence of these medication errors varies from depending upon the various studies, depending upon the type of setup and the ability to pick up these medication errors. It ranges from nearly 1%, even sometimes it may be less than 1% also, to 77%, depending upon the area where these medication errors have been found, or the type of setup. That is, either the errors have been looked in the primary care center or the secondary care centers or the tertiary care centers, and in which type of setting, whether it's the inpatient group or the outpatient group, and from whom we are collecting the medication errors, either from the registered medical practitioners or the people who are directly taking the medicines from outside. So depending upon this study group, the error or the medication errors prevalence is varying. But whatever it may be, it is causing a lot of impact on our healthcare profession as well as the health economy. And whatever we are seeing is only the tip of the iceberg. That means the errors that has been reported, whatever we are seeing from 1% to 77%, is only the tip of the iceberg. What we are seeing the errors outside. But there is a lot and huge number of medication errors that has been still underreported because of the various reasons in the that are prevalent among the healthcare professionals or the patients it might be. So before going into the medication errors as such, so we need to know about what is this actually the medication error, or what are these definitions that comes under this medication errors. So that United States National Coordinator Centers for the Medication Error Reporting and the Prevention, it has given the definition saying that it's any preventable event. You please just see this preventable event. This is more important. Any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional or the patient or the consumer. These events may be related to the professional practice, healthcare products, procedures, and the systems, including the prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Even though it's a very big definition, it includes all parts of the where the medicine is being used, right from its preparation, dispensing, storage, dispensing to administration at various levels. Either it may be from the nursing, pharmacy, nursing, or the healthcare professional, or the doctors, or the pharmacist. So at all these levels, the events which are occurring will come under this medication errors. And most importantly, it is a preventable event. That is why we are stressing on this medication errors. Right? And the other definitions which we need to know is adverse drug reaction. So adverse drug reaction, as we know, is any response that is noxious or unintended or undesired which occurs at doses normally used in humans for prophylaxis, diagnosis, therapy of disease, or the modification of the physiological function. It is a WHO definition given for the adverse drug reaction. And to say adverse drug reaction may or may not be preventable. Sometimes it may not always preventable. We can only treat the idea that has come resulted from a drug and take necessary steps to reduce the reaction rates. And sometimes we cannot even prevent this ADR. And the other term which we need to know is the adverse drug event. So what is this event? Event is any injury from a medication or a missed or inappropriately dosed medication. If you observe the difference between the reaction and the event, in the reaction, the dose of the drug is a normal. The drug which is given for a therapy in a normal dose. But in an event, the dose may also vary. That means either due to the inappropriately dosed medication, or it may be a missed medication, or the higher or the lower, either it may be anything. So any event that is occurring out of this is called as an adverse drug event. And here the patient suffers a negative consequence from receiving a drug in the usual manner it was intended. And they did not receive a medication that was required or receive the medication. As I told you, either the medicine may be taken by the person or may not be taken by the person, or at a higher dose it may be taken. So this results in the adverse drug event. And the other important term which we need to know is a medication misadventure. So what is this medication misadventure? It is anything, any event that is caused because of the healthcare profession, that is iatrogenic incident that is inherent to the medication therapy. Anything which is related to the healthcare profession. Iatrogenic means related to the health, which in the premises of the hospital. So it or due to medicine. So it includes all these things which we have discussed just now. That is the medication errors, adverse drug reactions, as well as the adverse drug events. And it may be either due to the omission or commission of the medication administration. And one more important term which we need to know is a sentinel event. So what is the sentinel event? So whenever this error what is occurring out of the medication, if it results in an unexpected occurrence involving the death or serious physical or psychological injury or the risk thereof, that means a permanent disability, or which may result in the seriousness or serious hospitalization which may harm the life of the person. So that is called as a sentinel event. So it may be anything related. It may be arising out of the event or the reaction. So when does this medication? So we have now discussed about the various medication terms used in this medication errors or the medical misadventures. And when does this medication errors occur? So when is the possibility that these errors occur? So whenever the administration or the medical framework is not proper, or due to the human factors also, that means overburden or the overload of either the patients or the doctors or the any healthcare professionals out of fatigue, or the poor environmental conditions that are prevailing in the healthcare facility, or due to the out of stress or out of the workload, they may it may lead to the errors either in the ordering or prescribing or the documentation of while documenting the medicine, or transcribing while explaining to the patient, or the dispensing, administration, or while monitoring the practices. At any of these levels, the medication errors may occur. And most frequently what has been observed in the studies is errors occur most commonly during the administration. But however, we need to understand that errors may occur at any stage of the medication process. And why it is important? Already this we have we have discussed because of the great impact that is caused by the medication errors. We need to know about the medication errors, and if we know about the medication errors, there is a greater chance that we can decrease the medication errors and thereby improving the system as well as the practices of the medicine, and ultimately the patient safety will be improved. So coming to the types of medication errors, there is various types of medication errors depending upon the classification of on what basis we are classifying it. Suppose if we take the classification based upon the sequence of medication use process, so medication errors may be classified into prescribing errors. That means prescribing errors means whenever the doctor or the pharmacist is prescribing a particular medicine, there may be a chance that wrong medicine may be prescribed, or wrong dose may be prescribed, or wrong time, wrong duration, or wrong route of administration. All these comes under the prescribing error. And transcribing, while explaining to the patient or while explaining to the nurses, whenever the person is, we are transferring the information to the other. So there is a chances that the error may occur. Those are called as the transcribing errors. And the dispensing errors. Dispensing errors means here, while giving the medicine to the patient or to the any other person, patient attenders, there is a chance of error of giving a wrong medicine or wrong dose because of the various factors. When the two medicines are looking alike or sounding alike, there is a chance that we give a wrong medicine and giving a wrong, dispensing a wrong medicine. And while administration is at the level of the nursing or by the patient itself or the consumer. So whenever they are taking, there is a chance that instead of taking the correct dose or correct route of administration and correct duration, there is a chance that they may take in improperly or in a wrong way. And also monitoring, whenever the patient is on medicine, and what precautions to be taken and what may happen if that is not taken care. Sometimes it may lead to errors also. And based upon the type of errors occurring, where that error is occurring. So depending upon that, medication errors are classified into when we are giving the wrong medication or the wrong dose, wrong frequency, wrong route of administration, and giving to the wrong patient. And the other type of classification of the medication errors is based upon the mistakes that happens, how the mistake is happening. That means knowledge while planning the action. Here, we don't have the proper planned action or the properly planned SOPs are not there. But while giving the medication, because of the knowledge, deficiency in knowledge, where the doctor may not be particularly aware of the disease, or because of the complicated patient who had seen, or because of the deficiency of the patient clinical history, all this may relate to the errors on the knowledge based or the rule based mistakes, or errors. Already the plan is well planned, protocols are there for giving the medicines, but because of the various slips or lapses, that means while giving the medicines, there will suddenly we may forgot one thing, that is called as a slip, or the memory based, that is lapses. Sorry, when we are giving or doing something, we miss one action, or we miss one route, or we miss one dose. There is a kind of action or slips or lapses may occur because of the memory base. Sometimes we forget the things. So these are some errors. And apart from this, another type of classification is also there, which is depending upon the drug storage, deteriorated drug error, where due to the storage, due to the change, or due to the place of storage, or maintain the ambient conditions to store the medicines, sometimes the drugs may get spoiled, which may lead to the errors outside. So because of the compromised storage, that is one thing. And second thing is drug utilization process error, that covers everything like the administration, dispensing, or monitoring, or the prescribing errors. And depending upon the severity, all these are depending upon the various routes, or depending upon the knowledge of the person. This has been based upon the severity also. The medication errors have been classified into various types. So whenever the medication error doesn't cause any harm, there is no error, then it is classified from A to I. This classification is also given by the same NCC-MERP, US NCC-MERP, where category A of errors we call them as where the error doesn't occur, but there is a chance that the error may occur, where the capacity to cause the error is seen. And second category, error is there, but it doesn't harm the patient. In this, we have the three categories, that is B, C, and D. B means error had occurred, but it did not reach the patient. That means the patient has not taken the tablet, or we have found it early and we have warned the patient not to take it. Type C is one where the error occurred that reached the patient, but it did not result in any harm. And type D is one patient, the error occurred and reached the patient, and with slight monitoring, the patient result. We know that the patient has occurred and we are taking care of the harm. And it doesn't cause a severe harm here. And the error and causing the harm, here we have the different categories like the E, F, G, and H, where E is error had contributed to some harm, temporary harm to the patient, and we need some intervention for that particular harm. That means some treatment is being given for that error. And type F is one where it requires the prolonged hospitalization, or first time because of the error the patient is getting admitted into the hospital. It is called as a F. And category G, if you see, it has resulted in some permanent harm to the patient. H, and the error had resulted in the harm, and it may lead to the where we need to interfere, like in the ICU based admission, where we need to interfere to make the patient alive. That is called as a type H. And last one, that is type I, where it is called as an error leading to the death of the, where the patient, the error had resulted in the death. So this is about the classification of the medication errors based upon the severity. And it's a small case study actually, where a 73-year-old man with a history of cardiac arrhythmia presented to the clinic for a routine follow-up visit. After being evaluated by his physician, patient received a handwritten prescription for Ridmol 150 milligrams, which he had been taking for the previous 3 years. He filled this prescription with the clinic pharmacy and subsequently started to experience nausea, vomiting, and an irregular heartbeat. After 2 weeks of the symptoms, he called his physician for an appointment, noting that his Ridmol tablets looked different than his last time. So what has happened? When the case has been looked back and has been evaluated, so what drug he has been received is, he had received the drug levothyroxine instead of the Ridmol. The dose is same, but the drug that has been given is entirely different. So because of this thyroxine, the patient is experiencing the nausea, sweating, and irregular heat. So what type of error it might be? Here the prescription is correct, but the pharmacist who had been dispensing the drug is wrong. So it's a type of dispensing error. This is one such example. So coming to the various factors that may influence this medication errors, it may be at the various levels, that is the healthcare professionals, patients, or the work environment, medicines, or the different tasks, computerized information systems, or the primary secondary care interface. So coming to the healthcare professionals, if you see how the factors may influence. So if a healthcare professional, in case he is not, as we have seen in the knowledge-based medication error, if he is not having the much knowledge about the particular disease or about the patient especially, or not aware of the circumstances that is happening around him, or because of the work overload. Work overload is a very, very important thing where commonly the mistakes occur in case of the healthcare professionals. So work overload, or because of the fatigue and the long queues. So all these may impact the healthcare professionals in committing the mistakes. If you see the patients, so patients, if they are not who are not able to communicate well with the healthcare professionals, not able to understand the whatever the advices or the that the healthcare professionals had given to them, if they're not able to communicate with them properly, not able to receive or understand the what has to be taken and how much to be taken and at what time to be taken, if it is not properly communicated, the patients may, there is a chance that they may take a drug in a wrong way or wrong dose. A simple example I can tell you here. Everybody knows for the bronchial asthma, usually the beta 2 agonists are being given. So the various forms of the beta dose inhalers, rotahalers are available. If you see the rotahalers, so how they are available? They are available as a capsules. So if we don't, healthcare professionals are not able to communicate these things, what to do with the capsule now? Whether the capsule has to be taken orally or the capsule have to be inhaled, keeping in a rotahaler. And how to use the device, that also has to be taught to the patient. If it is not being taught, there is a chance that these patients may take these capsules orally and ultimately ending up with the increased or severity of the disease. So in this way, the proper communication is important. And the patients also should be able to understand what the healthcare professional and the language barriers or the literacy problems, all these factors influence the medication errors. And the work environment, if you see, the work environment is very, very important. If you are working in an environment where the operating procedures are well framed, and the people who are working there are not under the stress, and the not overburdened with the work and too long queues. So it all counts where the work environment doesn't influence the professionals as well as the patients in exactly communicating what they are doing and what the patients are receiving. And the medicines, if you see, this is a very, very important thing. The proper storage is very, very important of the medicines. If they are not properly stored, so it may lead to the spoiling of the medicines, which may result in either decreasing efficacy, or sometimes it may lead to the adverse reactions also. Or if any growth is there, especially in the IV fluids or the medicines or any types of parenteral injections, if not properly stored, it may lead to the various fungal growths in or the bacterial growths in the liquids especially, and which may lead to some errors. And so proper storaging is important, and proper dispensing also by the pharmacists who are working there. Proper picking correct medicine with correct dispensing also. This is important. And the task, how the whole alignment is being going on. If there is any deviation in this task, which is being either right from the prescribing to the patient receiving the drug and then taking the drug till the patient taking the drug, if anything is not aligned, then it may lead to the error. And nowadays, as we know, everything is computerized, and even we see that the whole a particular group of drugs are also being given for particular diseases. It has been prepared in such a way that if a patient comes with one disease, the whole lot of medicines will be present in that particular prescription, so it will be dispensed. So there is a chance whenever there is a flow of people, or we can dispense a wrong prescription or to a person who is having the wrong with the particular disease. So whenever we are dealing with the computerized information system, the alert and the what type of medication that has to be taken care of. And the primary secondary care interface, this occurs usually whenever patient is being shifted from one place to the other, right? When the patient from the emergency unit, when they are being shifted to the ICUs, there is a chance that the mismatch or the transfer of information may not be proper, which may lead to the medication errors, or from the ICUs to the wards, or from the patient is discharging from the excuse me, from the hospital to the home, or referring to the higher healthcare center. At all these levels, there is a chance that the error may occur while changing or the transfer of information from one person to the other person. So all these errors, all these are the places where the errors may occur. So how to overcome this? So this already I have discussed this in the various factors. That means expired product, which is due to the medicine, improper storage, or not taking out the expired medicine at a proper time and keeping the medicine like that only, so dispensing the same medicine, or incorrect duration, preparation, strength, excuse me, rate, timing, dose or dosage form, or the patient action. And sometimes, as I know, you knowledge based, if the known allergen, the patient is already allergic to some particular disease, but the exact history is not being retried by the doctors or the physician, or the patient may not be telling that particular history. So in such cases also, or the known contraindications, already we know that this drug should not be given in particular disease, but out of fatigue or overloaded with many problems, or not able to retrieve the particular information from the patient, all this may lead to the errors basically. And distractions or distortions are the one which are also seen most commonly in case of the work overload. And legible handwriting, which is very, very important. That's why even the MCA or the NMC is insisting to write the prescriptions in the block letters only. But hardly we see the prescriptions written in the block letters anyway. So these are some examples where the look-alike medicines, if we observe these two medicines, two vials, where you can see they look very exactly similar. But if you see the content inside, one is the heparin, the other is the lignocaine. And a large difference is there between the two medications. If by suppose if we give the heparin in case of the lignocaine, So, especially in case of surgery, it may lead to the deleterious effect. In case of malignant effect of the heparin, so bleeding may occur and patient may go into some shock-like syndromes. And the second example, here I'm quoting only a few examples. This is like where you can see these are the ephedrine sulfate, and in the middle we have one vial which is looking very much similar to that of the ephedrine, like the heparin. So these practices are very commonly seen outside as well as even in the day-to-day practice. If we go to the hospitals, we commonly encounter these things where the look-alike medicines or the serious hazard to the medication errors. And apart from this, sound-alike medicines. So when doctor is telling something, the nurse or the pharmacist could not able to hear properly, or the patient could not able to hear properly, and they may give or dispense some other medicine. So the sound-alike medicines is another factor which causes the medication errors commonly. And ISMP, that is the Institute for Safe Medication Practices in India, had given a big list of medicines in India which sounds alike. And there is always a chance that whenever we are uttering a word, there is a chance that it can be misunderstood by the other person. So in this way also the medication errors occur. Some of the changes after seeing the various errors and have been reported resulting in the serious adverse events, some of the changes that has been made in the drug labeling to make it clear between the different doses of the various drugs. Here is one example which is given or made by the US FDA, where the losartan, all the 25, 50 and 100 mg, all the three are looking alike. So after being the medication errors being reported, it has been changed to, it is a color changes where we can identify clearly 25, 50 and 100 mg so that the patient doesn't take the overdose or the underdose. So these are some practices which we can make by reporting the errors regularly and for the patient safety. Not only the patient safety, it's for us also. So the most common system failures, if you see, these are the common things which we face outside, that inaccurate order transcription or the drug knowledge dissemination, as I told you, and properly not able to obtain the allergy history, incomplete order checking, or mistakes tracking the medication orders, or poor professional communication, or the inaccurate patient information. So it's just gist of it where the errors are being occurring. So coming to the errors, like what may happen when the errors occur. So medication errors, it may lead to the various health consequences. That means result in the poor quality of life, or increase in the severity of the disease sometimes. Economic consequences, as we know, it may lead to the huge amount of money we need to spend for this medication errors, and as it increases the use of the health services, and sometimes it may lead to the death of the patient also, as these are the preventable ones. So medication errors are the ones which can be prevented at every step. Either it may be at the prescribing or the administration level or the monitoring level. At every stage, these are the preventable ones. So these helps in decreasing the hospital admissions also. And so this may lead to the whatever the medication errors that are occurring may lead to the either the adverse drug reactions or the drug. So what these drug interactions also may lead to the medication errors. So various drugs, especially in the polypharmacy in the elderly people, as the life expectancy is increasing, the many people will be having the many chronic ailments. So the people are prone to use the multiple drugs, which is the main factor for the drug-drug interactions, which we are going to discuss in the next session also. And which may lead to the errors. Sometimes this medication errors may lead to because of the patient adherence, as I told you, which may lead to the poor quality of life and patient experience, and the lack of efficacy of the drug may be resulted. These are the outcomes of the medication errors. So out of this medication errors, here is a story of Martha, which I would like to tell you, where the WHO has initiated the patient safety, where we need to focus on the patient safety. Martha is a person who wants to, or who is thinking to become a good nurse and practice in the healthcare profession, who was dreaming about her career, and unfortunately, what had happened to Mata is she was suffering from the hypokalemia now and then. In between, while during her nursing education, she had some mood disorders, that is bipolar disorders, where she had been prescribed the drugs like the Radium, and which has resulted in the heart problems and arrhythmias. This has been informed to the healthcare professional also, but somehow because already she had the previous episodes, somehow it has been neglected, and ultimately after some 15 days of being prescribing this drug, it has resulted in the death of Mata. And after 5 years of the death of Mata, because initially they thought it was a natural death, because she has been suffering from and then nothing has been proven, and the people and the parents were behind her, behind the court and everywhere, where they have been dig the case and found that it is due to the where the persons or the healthcare professionals are not able to identify the medication error which has resulted in the death of the Martha. So it's a like this Martha, we could see many stories which have been seen around the world, even in our country too. So to decrease the such incidents, the WHO and initiated the patient safety, that is medication without harm. So it has taken it as a challenge in the third global patient safety challenge, that is medication without harm, which has started in the year 2017 at Germany. Main motto being the patient harm generated by unsafe medication practices, do no harm, and medication error, to decrease the medication errors as far as possible. So this is the main motto of the WHO third patient global safety challenge. And the objectives of this global challenge is, first, you assess what are the medication errors that are present in your area or in your hospital, and it invites all the stakeholders throughout the world to take part in this initiative. So before starting this challenge, what we need to do, we need to prepare ourselves how to make the things, or how to decrease medication errors. So what we need to do, first we need to assess our environment, what type of errors are occurring in our hospital. That is the scope and nature of the avoidable harms that are occurring, how much percentage it is occurring, at what level they are occurring, and what are the things that are happening there, and who is responsible for that. So all these things we need to assess first, and then create a framework for action, what we need to do now. So to decrease the medication errors, what we need to do, and develop the SOPs or the tools, and make use of the technologies, that is computerized softwares, to make to prevent or decrease the errors, and develop the standard protocols, and involve all the stakeholders in the plan, right from the healthcare professionals, that is the doctors, pharmacists, nurses, all these people has to be involved, along with the patients and the administrative people. So involve all of them to get engaged in this plan. And also, the most important thing, the ultimate people who are suffering from the medication errors or the patients. So we need to empower the patients, their families, and the caregivers about the knowledge of how the errors may occur, and ability to take the decisions, what has to be taken, or what decision has it. You give the treatment options to them, and tell them to choose the treatment option, that means taking the decision by themselves, and asking the questions, and spot errors if any, and reporting such errors. So these are the things, based upon this framework, the errors may be decreased. And the same thing, so under this patient safety, they have identified the 4 main patient domains where the safe medication practices can be implemented. That is, the patients and the public are the one, the medicines from where they are being prepared and dispensed, and the healthcare professionals, and the systems and practices of medication, that means the whole environment. So under these 4 main domains, the 16 subdomains have been identified. So under the healthcare professionals, it has been identified, we need to increase the knowledge of the healthcare professionals by regularly educating them. That is, continuous medical education programs need to be conducted, training the healthcare professionals in their areas to decrease the medication errors, and how to communicate the prescription. The communication skills are very, very important for everyone, not only the healthcare professionals, to properly communicate what has been prescribed to the patient or the other healthcare professional, that is either the sisters or the pharmacist. And the importance of teamwork, because no one can do the work by themselves. Teamwork is very important, and the stressing on the teamwork is important. And the point of case, suppose in any case of the error has occurred, so what to do for that? So all these things, the standard procedures have to be developed. And the most important thing is, whenever a report has been identified, you need to report it. So any error that has been identified in the healthcare setup, we need to report it and learn from that. How can we decrease the error? What necessary steps to be taken to decrease such type of errors? And most of the times we face the problems from the healthcare professionals or the other people who are working in that area. That means if an error occurs, they think that it is something which may cause harm to such persons. But reporting helps in making ourselves or improve ourselves. That is about the healthcare professions. And under the medicines, as we have discussed previously also, so quality of the product and has to be checked thoroughly. And without the quality of the product, those medicines like the spurious medicine should not be released into the products. So thorough regulatory practices has to be invoked. And as we have seen, look-alike medicines. So naming, proper labeling has to be done, and proper packaging and proper storage and proper dispensing of the medicines should be taken care. And how we are dispensing them, and whether the authorized person is dispensing the medicine or not. So all these things has to be taken care regarding the medicines. And the system practices means where the leadership or the governance, where the particular environment, where they have a good framework of the healthcare facility with the standard operating procedures for all the types of medication practices. Either it may be at the prescribing level or the dispensing level or the administration level. So standard procedures has to be framed, and ability to handle the errors if occurred, and able to monitor them and give proper treatment and decrease the error rate or outcome. And patients and public, as we have discussed, under this we have the domains creating the awareness among the public, engaging them, and reporting. We need to create the awareness among the public also to report. How to report these medication errors is very, very important. And this has been mainly planned against the 3 action areas. As we know, the polypharmacy, which we have already discussed, especially in the age group of the elderly patients, where the WHO is insisting the stress on this polypharmacy, as well as the people with multiple disorders and high risk situations. That is either in the people, children, or the elderly people, or in the pregnancy and lactation group, or the complicated cases with the multiple disorders. In these high risk situations, how the errors has to be tackled. And transition of the care, which is one important area where the patient is being transferred from one area to other area. So these are the areas of the focus, and how we can decrease the medication errors by proper planning. And this is one patient related one. These 5 movements for medication safety, which the WHO has given in 2017, like right from the starting of medication, how to take the medicine, adding a medicine, or reviewing the medicine and stopping the medicine. How to take care has been given as a poster. And many apps are also being, MedSafe apps are being available in the app, Play stores, which we can download and learn about them, or what are the safety things which we need to know about the medicines, and how they can be avoided. So these are some errors. As I told you, the medication error reporting is increasing, but still the reporting has to be increased. Whatever the reporting that has been seen is only the tip of the iceberg, as I told you. Still, it has to be improved for the safety of patient. So this is about all about the medication errors. So in summary, so medication errors are the ones which are the preventable errors. So by joining hands in reporting and maintaining a standard health framework, and burden of the medication errors can be reduced greatly. Any questions from the audience? Is it audible for you, or am I lost?
Audible, ma'am.
Yeah, thank you. If any questions are there, I'm happy to take it.
Ma'am, thank you, ma'am, for the session. The session is very informative for us. So our students and our delegates have got some good information regarding what are the different types of medication errors and how to detect and prevent the medication errors, ma'am. So here are some questions from our students, ma'am. So I'll let you know. So Dr. Anirudh, ma'am, he has asked regarding, please kindly brief about primary and secondary interface in medication error factors, ma'am.
Primary and secondary interface means, suppose when a patient is in the primary setup, like in a primary healthcare facility, where the error, the patient is being referred to the higher center. That means we are referring the patient because we are not able to manage the patient over there, and we are referring the patient to the higher center. But by transferring the patient to the higher center, we need to inform the doctors at the higher center whatever the medicines that are being given at the lower center, so that there won't be any duplication of the drugs, or whatever the information regarding the proper history or about the patient, or what made the patient to come there. So all these details have to be properly transcribed to the higher center people, properly conveyed. Many times what happens, whenever we are referring the patient, they simply write refer to higher center, but they never write what has been the drug that has been given to the patient at the lower center. So suppose, for example, I'll tell you simple things like already the patient has suffered from a myocardial infection at the lower center. You want to refer to the higher center, and you had already given some glycerol trinitate over there, okay, and the patient had been referred to the higher center. All the drugs are being given at the lower center also. There is a chance that when the patient is being taken to the higher center, by seeing only the ECG report, there is a chance that the patient, there is a duplication of the drug of giving the same glycerol trinitate, and the hypotension may occur. So instead of to avoid all these mistakes, and sometimes it may be happen that already the patient nowadays, even these thrombolytics are available at the lower centers also. So there is a chance that they may push up a bolus over at the lower center, again refer to the higher center. If they don't write this particular medication history, there is a chance that there is a duplication of the drug at the higher center. So this is about the transcribing phase, where the patient being shifted from one center to the other center. Not only from one center to the other center, even within the hospital also. Suppose if a patient is shifting from emergency unit to the ICU. So if the proper handover is not being given to the sisters over there or the pharmacist over there, there is a chance there is duplication of the drug. Suppose the insulin being given at the emergency for treating the hyperglycemia, and again after shifting to the ward, if they don't mention it properly in the record, there is a chance that the same insulin being given after reaching the ICU also. So these are the nothing but the primary and the secondary interface errors.
Yeah, thank you, ma'am.
Yeah.
Thank you, ma'am. There is one more question.
Yeah.
Yeah, there is one more question from Chandana, ma'am, and she was asking like, how are medication errors prevented?
Prevented? I didn't get
How are medication errors prevented?
Medication ever prevented by proper taking care of the dispensing, for example, by giving a correct dose. If we don't write the medication error, nothing but writing an incorrect dose is also a medication error. So if you are very knowledgeable that the metronidazole, simple metronidazole should not be given more than 400 milligrams. So there is if you know that this drug dose is only 400 mg, then we write the same prescription. If the dose we are writing is just 100 mg of metronidazole, then it doesn't work. So this is nothing but preventing the medication error or correct route of administration, as I told you previously also. So whenever you are telling a drug, you need to mention the route of administration correctly, and how we are writing the units is very important. This is resulted in the many deaths actually, especially in the insulin cases, heparin cases. Insulin is the one where they mention as a units. If they mention it by mistakenly, these incidents have, if you see the net, these incidents are being reported in the internet also, where the person, suppose 10 units are there. People sometimes they take, because 60 to 70 units also sometimes they will be giving in case of the hyperglycemic coma, hyperglycemic episodes, severe hyperglycemic episodes are there. In such a case, they may be mistaken and taking the wrong dose. So these are all the preventable errors. Is it clear? Hope.
Yeah, thank you, ma'am.
Yeah. Thank you very much.
One more question from Lakshmi Daraboina, ma'am. And she was asking like, how can we bring awareness to consume regarding medication errors as pharmacists.
To consume, I didn't get it. To consume medication errors?
To consume medication errors, ma'am.
Pertaining to pharmacist. So pharmacist, what is the role of pharmacist actually? The example which I have quoted here also. So instead of giving the anti-arrhythmic drug, the patient had the pharmacist had given the levothyroxine there. So simply whenever, suppose if the doctor is not writing improper legible handwriting is one thing, or sometimes when the doctor is telling something by voice, when he is giving the prescription, sometimes a pharmacist may not be knowing or thinking a sound alike medication. If he thinks of another drug, then there is a chance that the pharmacist may give a wrong drug. That is one area where the error may occur. And second error means the role of pharmacist also plays in the proper dispensing and removing the drugs on time. So if they don't take out the expiry drugs from the pharmacy area, there is a chance that drugs may be given to the patients, because pharmacy is a place where there's so many people will be coming in. So if you don't take out the expiry drugs on time, and if you leave them on the shelf like that, there's a chance that you may give the expiry drug to the patient also. It happens many times. So and also look-alike medicine, if you see. So instead of giving one drug, if the dispensing is done in the other drug is being dispensed out of hurry. It may be out of hurry. I don't say it's purely the negligence, but out of hurry or out of stress, work overload, it may happen. There is a chance that the pharmacist area also the errors may occur. Most people in rural areas are not well educated, so they are dependent on pharmacists and on physicians. Then how can they report the error? That's why we need to create awareness for reporting the error. We know the people may not be educated, but we are educated. The pharmacist and the doctor or the RMPs who are for patients. There we have the patients, most of them are the illiterate basically, but they're asking questions about the this adverse drug reaction reporting. We wondered actually, but the people aware and very literate, they usually ignore all these things. But the people who are not well educated, they were very much concerned about their health and try to get the information. I don't think that education matters here. Maybe the opinion may differ with some, but it is the how they are being brought up, and usually they think they try to retrospect everything, or whatever they're trying to take it, they usually have many doubts and they ask for many things also. But reporting may be a problem, because we can create awareness, and or the pharmacist can collect, or the physician can collect the report and give the information.
Yeah, ma'am. One more question, ma'am. Thank you. And
Yeah,
a question from Sanjusha, ma'am. Can you explain where and how to identify and report ADR? How to identify and report ADR?
Where and how to identify the reports of ADR again will be dealt by in the next session, that is in the Pharmacovigilance Program of India, which is being, because that is the one which is organizing this week, National Pharmacovigilance Week. And how to report this ADR also will be then dealt by the next speaker, and how the various tools that are available for reporting this ADRs.
Yeah.
Okay.
Yeah, okay, ma'am. Thank you.
Yeah, thank you. Thank you very much, madam. Thank you, sir, for giving us this opportunity. Thank you, one and all.
Yeah, thank you, ma'am. The session is very informative, and thank you, ma'am, for your cooperation for making this session successful, ma'am. Further session of the webinar will be continued by Dr. Archana, ma'am. Thank you, ma'am.
Thank you, ma'am. Now I request Dr. Sujana, Assistant Professor, Department of Pharmacy Practice, to introduce the guest speaker, Dr. Mehdi Ali Mirza, to the delegates. Good morning, all the delegates and dignitaries, and myself, Dr. D. Sujana, and working as assistant professor in Pulla Institute of Pharmacy. And actually, in today's session, actually, Dr. Roja Rani Madam supposed to participate in this session, but due to the medical emergency, she could not attend this session. So, and also she conveyed her best wishes for the webinar. And later we contacted with an eminent speaker, that is Dr. Mehdi Ali Mirza. He is a man of virtue and simplicity, and I feel elated to introduce to everyone, that is our delegates and dignitaries. So when you come to his studies, he completed his DM in Clinical Pharmacology and Therapeutics in NIMS, Hyderabad, and MD in Pharmacology at Dr. NTR University of Health Sciences, and MBBS at Nanjing Medical University, we are in China. And if one takes a close look at his skills, and he is the master of various skills, which includes clinical research, that may be good clinical practices and designing of the clinical trials, and also conducting pharmacokinetic and dynamic studies in a healthy humans, and also teaching to medical and paramedical courses and staff, and also involved in the patient care, which may be therapeutic drug monitoring and drug information services and pharmacovigilance, and also antimicrobial step-1 programs. And it's not surprising for a delegate person receiving a promising awards that are Dr. G.B. Parul Award and Dr. A.D. Joseph Award, and also he is selected for UK SAFE Prize. And at present, he is working as an assistant professor in Department of Pharmacology at ESIC Medical College at Hyderabad. Now, I would like to pass on the next upcoming session, that is valuable time, to Dr. Mehdi Ali Mirza to share his wonderful thoughts and ideas on this present topics, that is drug interactions. As you already know that drug interactions is a major problem, and also it will occupy the major percent in the pharmaceutical interventions. So this leads to the irrational prescriptions, which causes the morbidity and mortality of the death. So please be in attention to get the valuable information from the Dr. Mehdi Ali Mirza. Now I'll request speaker to start the session. Thank you, sir.
Good morning, everyone. Am I audible, ma'am?
Yeah, sir, you are audible, sir.
So I am very thankful for the organizers from Reddy College and ESIC Medical College to allow me to talk today on this topic. And my topic today is drug-drug interactions. As we can understand with this, the topic name, drug and drug interaction, that means there is, when we take drugs together or concomitantly, when we take two drugs, one drug will impact the effect of another drug. It can either increase or it can decrease. So it will modulate the effect. The modulated effect can be inhibited or induced. So now we will talk about drug-drug interactions today. Like it's not only drug-drug interaction, we also have drug and food interaction, drug and herb interaction, drug and disease interaction, drug and lab values also will interact. So as per today, we will just talk about drug-drug interactions. Okay, so it is very important. My slides are not. Yeah, are my slides changing, ma'am? Okay, are you able to see my slides moving? Anyone? Am I audible? Yes. Okay. So.
Sir, audible, sir, and you can see that it's moving.
Yes. So my overview is, first I will talk about the epidemiology of drug-drug interactions. That is, how is the prevalence, how common it is, and types of drug-drug interactions. Generally, we have two types of drug interactions. One is pharmacologically, pharmacokinetic based and pharmacodynamic based. Okay, pharmacodynamics is what drug does to us, to our body, and pharmacokinetic is what we do to the drug. So majority of the drug-drug interactions are based on pharmacokinetics, and that also includes alteration in absorption or distribution, metabolism or elimination, ADME. So all four will be target for drug-drug interactions. The majority or major contribution for drug-drug interaction is with the altered metabolism. So remember that it's because of altered metabolism, major drug-drug interactions will face. And sometimes we'll have complex drug interactions also, which involves all the modalities, like it may affect the absorption simultaneously, that may affect the distribution, metabolism, excretion, more than one level of pharmacokinetics. So first we'll talk about the epidemiology. Epidemiology, actually the true incidence we cannot quantify of drug-drug interaction, but as per the reports which are available, a review has shown that out of 8,860 patients who receive 16.6% patient had more than one significant drug-drug interaction, and this was reported between 2005 and 2009. So it's a like 16% is a big percentage. So the major risk factors which are associated with drug-drug interaction are the age. Okay, elderly patients tends to, because they have polypharmacy and comorbidities, they are more prone to drug-drug interactions. And FDA, in 2013, from all the new drugs that were approved, we have found that 77% drugs were metabolized by CYP 450. Yeah, and 77% showed to be metabolized by metabolizing enzymes, and 85% showed possible interaction with target proteins. So overall, as I told, 45% has a metabolism based drug-drug interaction. So metabolism has a major role in drug-drug interaction, like clinically significant drug-drug interactions. So coming to the types of drug interactions, as I told, we have pharmacodynamic and we have pharmacokinetic types of drug interactions. Pharmacodynamics are related to drug effect on target, that's safety or efficacy. And one drug modulates that of the another, though the pharmacological interactions can result in additive effect, synergistic effect, or antagonistic effect. So we'll see that in the next slide. So the major group of drugs which are involved in pharmacodynamic interactions are psychiatric drugs, drugs used for convulsions, and hypnotics and sedatives and analgesics. Okay, and pharmacokinetics impact how a drug is absorbed, distributed, metabolized, or excreted. So this will decide the impact of concentration of drug at the site of activity or the site of toxicity. Okay, wherever the drug activity occurs, the concentration, like proper concentration should be reached. If it is less than threshold, it will be subtherapeutic. It is more than threshold, more than required, like upper limit, it will be toxic. So these all parameters will decide how much concentration is reached at the site of action and site of toxicity. As I told again, the most commonly the result of inhibition or induction of CYP 450 enzyme is having the major role. So we'll see first about pharmacodynamic interactions. Additive effects, additive combination. Additive combination means it is 1 + 1 is equal to 2, something like that. So when we combine two drugs, okay, the effect will be plus. If ibuprofen has 1 score and acetaminophen have 1 score, we'll get the score of 2, sum of the 2. So some additive combinations are beneficial, some are harmful. So as for pharmacovigilance, we are more worried about the harmful combinations. So the benefit is ibuprofen and acetaminophen, and harmful is zidovudine and ganciclovir. Zidovudine is an anti-HIV drug, antiretroviral drug, and ganciclovir is for CMV infection, cytomegalovirus infection. when there is superinfection of cytomegalovirus in HIV patient, these drugs were combined, and we have found the harmful effect that together they have caused neutropenia, so decrease in WBC or neutrophil counts. So that was the harmful effect. So synergistic combination. Synergistic combination is the when we have 1 plus 1 instead of 2, we are getting 4. That is known as synergistic combination. So when we individually, when we try to treat gram-positive infection with aminoglycoside, we get less effect. And when we treat with penicillin, we may get less effect. When we combine, we can cover most of the gram-positive infections. So that is the beneficial effect or synergistic combination. It can be harmful also, like in the case of barbiturates and alcohols. So because alcohol is a enzyme inhibitor or barbiturates are enzyme inhibitor, they can affect each other's concentration in the plasma and increase the sedative effects. You know, barbiturates follow very steep curve in their DRC. So there's with little increase in concentration of barbiturate that can increase the effect. It can even cause the death. Okay, so this is this harmful synergistic combination. Then antagonism. When we combine two drugs, one drug, if it decreases the effect of another drug, that is known as antagonism or antagonistic combination. That like 1 plus 1, if we do, it will be either 1 or less than 1. So one of the beneficial example is naloxone, which is an antidote for opioid poisoning. Overdose of opioid poisoning can be treated with naloxone. But harmful effect is again zidovudine and stavudine. These are the two anti-HIV drugs, and when they are given together in combination, they nullify each other's effect. Okay, they inhibit each other. Stavudine will inhibit zidovudine, and zidovudine in turn inhibits stavudine. So I think these are the pharmacodynamic interactions. Then next we'll move to pharmacokinetic interactions. These are important, more important, and it can happen at any level: absorption, distribution, metabolism, and elimination. So when we talk about absorption, like we know acidic drugs require basic medium for absorption, basic drugs require acidic medium for absorption. And it also depends on the gastric motility. If we are combining a drug with prokinetic, the gastric motility will be high, will be increased. Or if we are taking with the some other drugs which decrease the motility, there will be interaction. So there are 4 factors we'll discuss in the case of absorption. One is gastric motility, another is pH, chelation effect, and GI transport proteins. Okay, transport proteins have actually role at all the levels, at absorption, distribution, metabolism, as well as excretion. And distribution, we'll see about plasma protein binding, and metabolism also we'll see enzymes as well as transporters. And elimination, we'll see biliary and renal secretion. So we'll see each one in detail. So I'll start with altered absorption. Altered absorption based on pH effect. So as you know, many drugs are dependent on pH for optimal solubility. So increased pH in the gut with H2 antagonist, for example, ranitidine, or proton pump inhibitors like omeprazole, these can decrease or increase drug absorption. I told you the mechanism, because some drugs which are acidic, they need acidic medium for absorption, and basic drugs needs basic medium for absorption. So that will affect. So examples, like most of the examples we have taken in this talk is related to either HIV or cancers. So first example is atazanavir. It is an anti-HIV drug. When it is combined with omeprazole, what happens is atazanavir area under curve, AUC stands for area under curve, decreased by 94%. So what can be the reason? The reason is it needs, it's an acidic drug and needs acidic environment, okay, for absorption. But because of decrease in acidity, the environment has become basic, so we have got decreased area under curve. So in the opposite way, retinavir is a alkaline drug. Okay. So its concentration when it combined with omeprazole, its area under curve increases by 3 folds. So though these are important, but clinically they may not have much impact. But this drug, the third drug, erlotinib, which is an anti-cancer drug, when it is combined with omeprazole, because most of the cancer patients simultaneously have acidity also. So they might be prescribed omeprazole. And the main anti-cancer drug oral which they are taking every day is erlotinib. Okay, this will decrease the area under curve by 50%. So 50% drug has decreased in the plasma. So, but the impact of this reduction has been studied retrospectively. A retrospective review of patient record found concurrent treatment with acid suppressor or an erlotinib was significantly associated with shorter overall survival after accounting for other factors. So see, the lifespan has decreased to 12.9 months versus 18.9 months. So there was a significant interaction which has morbid response. So this was about pH. Now moving to absorption based on gastric motility, altered absorption based on gastric motility. So some drugs that decrease gastric motility, for example, methadone. Methadone is an opioid analog. So opioids generally cause constipation by decreasing GI motility. And some drugs will increase GI motility like metoprolol. It's a prokinetic. So these will also modulate bioavailability. So you see this diagram or in this graph, this represents area under curve. Okay, these are two area under curves. So there is decreased motility by methadone. Methadone has decreased the motility. It is so when we see diadenosine is an again anti-HIV drug. So when we have given diadenosine alone, okay, there was area under curve was larger compared to when we have combined diadenosine plus methadone. Methadone has decreased gastric motility. So area under curve has decreased. So when gastric motility has decreased, actually what is happening is most of the DDI is metabolized by the gut enzymes. When it is staying for a long time, it is getting metabolized and slowly getting absorbed. So bioavailability has decreased with this. Another example is increased motility by metoclopramide. It's a prokinetic. So posaconazole is the antifungal drug. So here also, when we see this plain circles, this triangles represent only posaconazole. So this is the normal area under curve of posaconazole. When we are giving loperamide, there is slight increase because of the decreased gastric motility. When we are giving metoprolol, there is actually decrease in the bioavailability because the drug is passing very fast. So it is not getting time to absorb enough. So this is the alteration in gastric motility. The third is chelation. You know, chelating agents. These chelating agents actually they combine, they form a bond with the drug and they nullify the effect of the drug. Okay, most of the time it will become water soluble and it is excreted or it is removed from the body. So chelation bonding is actually a irreversible bonding. So it is a irreversible binding of drug in the GI tract. Okay. So usually can be avoided by separation of the administration. We know that tetracycline, when we have tetracycline with the milk, so milk is having calcium. So the calcium in the tetracycline will form chelation and it will hinder the absorption of tetracycline. This is known as milk alkali syndrome. And in the similar way, quinolones, antibiotics. So whenever we take combinedly iron plus tetracycline or quinolone or antacids or dairy products together, the absorption will decrease because they chelate, these drugs chelate with these molecules. So here we see again, this is Trivofloxacin is an antibiotic. Okay, when we have given like 30 minutes back, Naloxone is an antacid. Okay, Malox is an antacid. 30 minutes back we have taken antacid, and after 30 minutes you have taken Trovafloxacin, an antibiotic. So area under curve is so less, bioavailability is less. Okay, when you have given a gap of 2 hours, okay, when we have given the gap of 2 hours, the bioavailability is high. So the solution or the to prevent this chelation, the main best approach is we should give a gap between taking the chelating agents as well as the drug. So the next okay, we have completed the pH. So next we'll go to the like we have even the transporters at the gut level. So the mainly the absorption of drugs takes place with the passive diffusion based on the molecular size and all. But there is a role of transporters as well. We have two different types of transporters. One are the uptake transporters, then the second are the efflux transporters. So efflux transporter, the most important example is P-glycoprotein. Okay, we should remember P-glycoprotein, and so here we are talking about altered transporters. So transporter protein in the intestinal lumen. So the main role is played by two major transporters. One is P-glycoprotein, which is a efflux transporter, and another is BCRP, which is a uptake transporters. So uptake and efflux transporters in the gut can be inhibited or induced by drugs. Like enzymes, the transporters can also be induced or inhibited, which may increase or decrease the bioavailability of drug that rely on the transporters. So substrate, that means the main drug, if the transporters are affected, then the concentration of the main drug will be decreased or increased in the plasma. So reliance on uptake or efflux transporter for absorption depends largely on compound permeability. The lower the permeability of the compound, the more its absorption is affected by the membrane transporters. Of the many drug transporters, only two generally, as I told, are associated with clinically significant drug-drug interactions. So one is P-glycoprotein, another is breast cancer resistant protein. So we see many anti-cancer drugs like transporters have role all in absorption, distribution, metabolism, and excretion everywhere, because wherever the organ barrier will be there will be a role of transporter, because with the help of transporter only the drug will transport from one compartment to the another compartment. So these are the two major transporters which has impact in the absorption through the gut. For example, drug interactions between quinidine. Quinidine is a P-glycoprotein inhibitor, and the substrate here is digoxin. When we combine digoxin with quinidine, actually digoxin will be effluxed from the gut. But when we are combining and inhibiting P-glycoprotein, there will be increase in the concentration of digoxin in the blood. And as we know, there is digoxin has very narrow therapeutic index. So slight change in the concentration may increase the toxicity of digoxin. So here the 2.5-fold increase in the amount of digoxin is absorbed in the presence of quinidine. So digoxin drug-drug interaction studies are often conducted as part, like when we do the new drug development, generally if we try to see the drug interactions present or not in vitro, we do use this model. Okay, and the clinical P-glycoprotein inhibitors include cyclosporin, erythromycin, and verapamil, itraconazole, and others. So these are used in the prediction of prediction studies for any drug-drug interaction of a new drug. Then that was about, yeah. This is the repeat, I think. Yeah. So that was all about the absorption. So in absorption, we saw the alteration in pH, alteration in motility, alteration in the transporters. Okay, they have their impact on drug-drug interaction. So when we talk about the distribution, so we have like distribution have like we discussed theoretically, we can discuss more about drug-drug interactions due to distribution, but it has very less impact. Actually, clinically significant interactions are less during the distribution. Okay, so as I told, theoretical mechanism of DDI for restrictively cleared drugs. Actually, clearance of the drug is of two types. One is restricted, one is unrestricted. When the clearance is dependent on the free drug, okay, because drug is bind to plasma proteins, whatever the free drug is there, only that drug is free for excretion or clearance. That is known as restrictive clearance drug. When it is independent of free drug, even bound drug is also getting excreted, then it is unrestricted clearance of the drug. So here we have the more restricted clear drugs have more impact on the DDIs. So only unbound drug in the plasma is cleared. Thus, free drug leads to an increase in total drug clearance and decreased plasma concentration. So however, unbound plasma concentration typically return to pre-displacement value after a transient increase. Actually, what happens is this is a short. When suppose a new drug has come, a patient was taking warfarin, okay, every day. And so what happens for when he has taken suppose first time, the prothrombin time is the dynamic effect. So prothrombin time will increase. Once that warfarin is getting washed, it starts decreasing. Prothrombin time again starts decreasing. So this is pharmacodynamically. Pharmacokinetically, what we see when we take warfarin, so after a few days, it will start decreasing. The concentration decreases. Okay. So suppose a patient was taking warfarin and then he took another drug which displaces warfarin because it is highly plasma protein bound. So only free drug will be available for doing the action of the warfarin. So when suppose we have given aspirin here on this day, so it will go and attach to the plasma protein and displace the warfarin. So free warfarin will be available more. So we will see there will be an increase in the plasma concentration of the warfarin. And this will be transient, means after some time, it will again match with the drug when it was not combined. So drug-free concentration returns to pre-displacement level transiently, only after brief period. So this is what this sentence says. So unbound plasma concentration typically returns to pre-displacement value after transient increase. So only as I told, only like the drugs which can cause significant drug-drug interaction after altered distribution should have the following properties. It should be high protein bound, and it should have small volume of distribution and narrow therapeutic index. So warfarin fits in all these three criteria. So warfarin has major impact when any drug comes and displaces it from the plasma protein. So I have explained this diagram. So like plasma protein, we also have the role of transporter proteins in distribution. So transport proteins play a role in the distribution of drug to organ system protected by a blood organ barrier, such as the brain, plasma, and the kidney. So what happens is some drugs, okay, will cause modulation. They can either inhibit or induce the transporters. So here I have illustrated few examples. Like loperamide is a substrate, and it was combined with quinidine. So quinidine interacts with G protein this one, not G protein, P glycoprotein, and cause inhibition. When it cause inhibition, that means the loperamide, it crosses the blood-brain barrier, but it is not efflux back. That leads to increased concentration of loperamide in the brain. Okay, so increased CNS penetration of the loperamide. So actually loperamide will be effluxed, but that efflux transporter is blocked, so it is remaining inside the brain, and it will cause all CNS toxicities. In the same way, digoxin, okay, when it is combined with paroxetine, it inhibits P glycoprotein, and CNS concentration of digoxin will increase. In the same way, these other two examples are there. Most important, penicillin. Okay, penicillin also, like it is the probenecid. So for renal clearance of penicillin, OAT is the transporter. So probenecid actually inhibits OAT. So penicillin will stay in the body systemic circulation for a long time, and it will have beneficial effect. That's why we combine penicillin with probenecid. So it prolongs the half-life of penicillin. So this was about the transporters. So next is metabolism. So like metabolism, we have completed absorption and distribution. Next, metabolism. We know there are two phases of metabolism, phase 1 and phase 2. And I told you, like in the beginning, metabolism have the major role in drug-drug interactions. So we have phase 1 where microsomal enzymes like CYP450 are dominant. They are present in gut as well as and liver, and they are the primary source of adverse effects due to drug-drug interactions. These are the various types of this pie chart represent various types of CYP enzymes, and the major CYP enzymes which are present are CYP3A4 and 5. And the second phase is conjugation like conjugation phase, which has a little effect, which is rarely associated with drug-drug interactions. So what happens to these enzymes? These metabolizing enzymes, they can either be inhibited or they can be induced. So when they are inhibited, what will happen? So we'll see altered metabolism, inhibition of CYP450 enzymes. So effect of inhibition on substrate exposure is greater if the substrate relies on the single route of metabolism. Means some drugs, they are metabolized by only one enzyme, but other drugs are metabolized by more than one enzyme. So suppose we are inhibiting this midazolam is inhibited only by CYP3A4. And if there is a drug which inhibits CYP3A4, then the concentration of midazolam will increase and it will reach the toxic level. But if it has more than two routes for metabolism, like voriconazole, it's metabolized by CYP2C9, 2C19, as well as 3A4. So when we are blocking, suppose CYP2C9, these other two enzymes will take care of it, and the impact will not be so clinically significant. So that is the main thing. And as well as enzyme inactivation will be, sometimes it will be irreversible also. So metabolic inhibitory complex is formed. That time when it is irreversible, we have to wait for the generation of new enzymes or restoration of activity of new enzyme. So this is generally caused by macrolides or grapefruit juice. Okay. So we see in this diagram, suppose a person is taking every day antihypertensive drug. So drug will normally reach its steady state concentration after 4 to 5 half-lives, and then he continues it every day, and his steady state concentration remains constant. Suppose you have given another inhibiting agent. When you have added the inhibitory agent, the concentration of drug starts increasing. So once after reaching again, if you are maintaining the dose, after reaching steady state, then that means a new steady state is achieved after a few days. Okay, so this just I want to make clear that with inhibitor, if we use it continuously, the steady state concentration will shift. Okay, and this will happen fast in the case of inhibitors. When we take single dose, what happens is, like in the case of trazodone, it is metabolized by CYP3A 100%. This is the only enzyme which metabolize it. Okay, so when we are inhibiting CYP3A by ritonavir, what happens? The area under curve has increased so much. It has increased 20 folds. Okay, because drug is not getting metabolized by CYP3A as it is inhibited. But when we have 2 or 3 pathways, like in the case of zolpidem, it is metabolized by CYP3A 60% and 40% by other CYP. So there is only 28% increase in area under curve. And zolpidem, as we know, it has a broad therapeutic window. So it doesn't affect much clinically. So this was about inhibition. When the altered metabolism is an inducing agent, like inducing agent, this happens, the mechanism is it involves increased DNA transcription via nuclear receptor activation. Like means with these nuclear receptor like PXR, CAR, there is increase in synthesis of the new enzymes. So when there is increase in synthesis of new enzyme, the drug will be metabolized faster. Okay, so but the effect of induction is slow, as it involves the synthesis through nuclear receptors. It is slow. Offset is also slow. So this depends on the half-life of the inducer, time to make new CYP proteins, and rate of degradation of CYP proteins. Okay, so as unlike in the inhibitors, where we have achieved the inhibition like new steady state based on the induction agent, here it will be fast actually, but here it will be slow. It will take over 2 weeks. Suppose in this example, it has taken over 2 weeks to again achieve a new steady state concentration. So the examples you see here, like CYP induction, and this is also independent of the, if suppose induction is independent of the, like multiple enzymes are involved, but it has significant impact, unlike inhibition. So there is a drug PA824, which is a anti-TB drug, new anti-TB drug. When it was combined with rifampin actually inhibits CYP3A. Okay, so when CYP3A, when only PA824 was given, this was the area under curve. Okay, and this was a Cmax 7.5. When it was combined with rifampin, which is a strong inducer of CYP3A, there is decrease in the Cmax as well as area under curve. So PA824 area under curve is decreased by 66%. Cmin is also decreased by 85%. And half-life of the drug has also decreased from 19 to 8 hours. So this is the impact of induction. So as I told, CYPs have the major role. So these are the list of drugs and which have strong, moderate, or weak inducer or inhibitor effect on various enzymes. So after enzymes, we'll talk about the elimination. So drugs are eliminated by either bile or it can be eliminated by renal secretion. So when we talk about this hepatic, there is a role of proteins, and the major role of the proteins, like this is the liver cell, and these are the uptake transporters, OATP1B1, OATP1B3, OATP2B1. These are the major uptake transporters. So the drugs will be uptake from these, and there are certain efflux protein transporters also, like P-glycoprotein, BCBR. So this will efflux the drug in the bile. Okay. So if we block the uptake inhibitors, uptake transporters, what will happen? Drug will not go into the liver and it will not get metabolized. So the systemic concentration of drug will increase. Okay. When we block the efflux also, when we block the efflux, actually efflux transporters were effluxing in the bile. So, but if we block it, the drug will be less secreted in the bile. So we'll see. So the inhibition of uptake transporter decrease hepatic uptake. So less hepatic metabolism, higher systemic exposure. And inhibition of efflux transporters decrease biliary excretion. Actually, this is increase that will also lead to increased systemic exposure. There is a mistake. I'll just rectify it. So increase hepatic metabolism. So like here we see in this case, okay, this is a uptake transporter OATP. It is inhibited by gemfibrozil, okay, anti-lipidemic drug. So when we combine, suppose we have given only rosuvastatin, which is an anti-epileptic, anti-lipid drug, okay. This is the area under the curve. When we combine gemfibrozil with rosuvastatin, the area under curve, actually this was with the only rosuvastatin. When we combine, area under curve has increased. Okay, so there was an interaction. OAT, this uptake inhibitor was blocked, at uptake transporter was blocked. So systemic circulation of rosuvastatin has increased. So in the same way, many transporters actually they will have contracts like CYPs and transporters in will have interplay, complex interplay. So suppose the same enzyme, same drug, okay, cyclosporine, it will inhibit the transporters as well as enzymes. So this efflux transporter it is inhibiting, it is also inhibiting the uptake transporter and it is inhibiting the CYP enzyme. When we combine this, atorvastatin, when we combine atorvastatin with cyclosporine, there is 8.7 per folds increase in the concentration of atorvastatin. Okay, in the same way, it happens with the other drugs. So we can like not only a single target, we can have multiple targets for drug interaction as well. And in the case of renal as also, we see these are the uptake transporters, OCT2, OAT1, OAT3, and these are the efflux transporters. So here also the inhibition of these transporters leads to alteration in the drug systemic concentration. So inhibition of the uptake transporter OAT1, OAT3 decreases the renal elimination and increase systemic exposure. In the same way, inhibition of efflux transporter decrease secretion in the urine and increase systemic exposure. For example, cimetidine, it inhibits OCT and increase metformin and pramipexole exposure. Probenecid, it inhibits OAT13 and increase cidofovir, furosemide, acyclovir exposure. So as I told you, we have completed absorption, distribution, metabolism, and elimination with various examples. So actually, it can be complex also. As we have discussed here, the same drug can inhibit transporters as well as enzymes. So there are various combinations which will impact the drug-drug interaction, even the disease status. Some patients will have renal failure and hepatic failure. That will further like modulate the drug interactions. So this was all about the clinical pharmacology of drug interactions. And we have various authenticate sources for drug interactions to find the data about drug interactions. And we also have some websites as well as some apps, but most authenticate are these sources are these like Martindale and so on. So that's all. Thank you so much. Any questions? Was I audible? What shall I say? Topic complete. So we have completed the talk. If you don't have any questions, then we'll move to the next session. Hello. Yeah, sir, I have completed my talk, but okay. We are online. We are not leaving. Okay. Yeah, we are on. Okay. Shall we continue? Yeah. Yeah, we are on.
Sir. And it's really important for all our delegates to improve our patient care. All the delegates, you can ask the questions if you are having any. Thank you, sir. So there are some questions asked by our delegates. Shall I ask, sir?
Yes, ma'am. Ma'am, what are the questions? Audience, if you have any questions, you can put in the chat box. Yeah, audience, if you have any questions, please post in the chat box. I'll try to answer. Otherwise, we'll move to the next section. On the YouTube also. On YouTube also.
Okay, sir. Okay, sir. The three questions are there. They answer. Sir, is there any specialized system for drug interaction reporting in hospital setting?
There was one question on YouTube by Bhanu Prakash sir. Sir, is there any specialized system for drug interaction reporting?
You can see this moving.
My overview is first I will talk about that reporting in hospital setting. Actually, we have talked by Dr. Ms. Jhansi, and she will explain that. I just want to say that in the form which we fill, which was designed by IPC, it has the list of drugs. So we will not write only the name of the drug which we are suspecting. It follows the list of all the concomitant medications which the patient is having. As well as there is a box on the left side where we can mention about the other herbal drugs or any new food they have added to their daily use. So with that we can predict, like we can go through various authentic resources and find, like if suppose the patient is on paracetamol as well as suppose he is on warfarin and aspirin, so we can go to authentic sources. Like one of the authentic source generally we see is RX list. RX list is a website designed by Australia, a medical council. So there we will check the drug interactions. If it's in the list of drug interaction, aspirin and warfarin are in the list of drug interaction, we will confirm or we will convey that message to the physician. Okay.
Still any more questions? Pharmacokinetic interaction. So how can we differentiate adverse drug reaction with drug interaction?
Yes, hello. There's a question about pH effect on pharmacokinetic interaction. As we have discussed in the slides, normally we know that in acidic medium, okay, acid drug will get easily absorbed. In basic medium, the alkalotic drug will get easily absorbed. Okay, for example, aspirin. Aspirin gets absorbed in the acidic atmosphere of the stomach. So if a person is taking antacid, okay, so what happens? Theoretically, I'm speaking. If patient takes antacid and aspirin, so aspirin will absorption of aspirin will decrease. So that is the effect of pH on the pharmacokinetic interaction. And another question is how can we differentiate adverse drug reaction with drug-drug interaction? So see, when a patient is taking suppose only single drug and you have recorded an adverse reaction, so directly we can attribute to that reaction, directly we can attribute to that drug. But if he is taking multiple drugs, suppose in the anti-TB treatment, he is taking rifampicin, isoniazid, okay, ethambutol, and paracetamol. So there is hepatotoxicity. Then what the major drug would have caused this hepatotoxicity? We know all the four drugs, 3 of the 4 drugs cause hepatotoxicity. So what we do to confirm the adverse reaction, we do the de-challenge and re-challenge. Okay, we'll withdraw one drug and see, suppose the symptoms are improving. Then that drug could be the interaction, could be the responsible for this reaction. Okay, so we de-challenge and re-challenge one by one. If we remove the drug, we will come to know which was the culprit drug.
Any more questions?
Thank you very much, sir. And now I'd like to ask Dr. Archana to continue the next session.
Now I request Dr. B. Sapna, Associate Professor, Department of Pharmaceutics, to introduce the other speaker, Dr. U. Jhansi Rani, to the delegates. Good afternoon, one and all. Myself, Dr. Swapna Velivela, working as Associate Professor from Pulla Reddy Institute of Pharmacy. It's my privilege and honor to invite and introduce one of our today's speaker, Dr. Jhansi Rani Madam. Madam has completed her PharmD from Vikas College of Pharmaceutical Sciences, Suryapet. She worked as clinical pharmacist intern and trainee in Kamini Institute of Medical Sciences, Narketpalli, as well as Aditya Birla Memorial Hospital, Pune. She has been awarded as Certificate of Merit as Best Intern for her sincerity, regularity, dedication towards her coursework. As well as she worked as clinical pharmacist in Continental Hospitals, Gachibowli, Hyderabad. Presently, she is working as Patient Safety Pharmacovigilance Associate from Indian Pharmaceutical Commission, Ministry of Health and Family Welfare, Government of India, Ghaziabad. The key job profile of Madam is collecting, monitoring, assessing, and reporting adverse reactions related to the medicines, vaccines, medical devices, and blood transfusions. With this brief introduction, I request today's speaker, Dr. Jhansi Rani Madam, to continue the program. Over to Jhansi ma'am.
Thank you, ma'am. Good afternoon to all the dignitaries, faculty, and the students. It's a great honor to be a part of this program. Thank you, Principal Sir and HOD of Pulla Reddy College for giving me this opportunity. Today I'll present about...
Over to Jhansi ma'am.
Is it audible, ma'am? Is it audible? Is it audible?
Yes, ma'am. Yes, ma'am. You can continue, ma'am.
Yeah, okay. Today I'll present the topic upon overview of pharmacovigilance. Is it audible?
Yes, ma'am. Yes, ma'am.
Okay. Before starting the session, I'll ask one question. Are there any safe drugs? You can post the answers in chat box. Are there any safe drugs? No, there are no safe drugs till now. And next question is, where is the National Coordination Center of Pharmacovigilance is situated? Where is the National Coordination Center in India located? You can post the answers in chat box.
Ma'am, your video is not clear. Just
okay.
And your yes, ma'am. Little, some more little.
Or my slides.
Yes, now it is okay, ma'am. Clear.
Or my slides are visible?
No, ma'am. Not at shade, I think.
Okay. Is it visible?
Yes, ma'am. Yes, now you can.
Yeah, okay. Yeah, most of them answered as New Delhi. It's approximately correct, but it is located in Ghaziabad, Uttar Pradesh district, Uttar Pradesh state actually. And where is the Uppasala Monitoring Center located? Next question, where is the Uppasala Monitoring Center located? I think most of the Form D students knew about it. Yeah, absolutely correct. It is Sweden. Yeah, okay. Today we'll go to the topic. Before going to the topic on pharmacovigilance, we'll learn the definition about the adverse drug reaction and adverse drug event. Adverse drug reaction, as per WHO, it defines as a response to a drug which is noxious and unintended, occurs at dose normally used in man for the prophylaxis, diagnosis or therapy of disease, or for the modifications of the physiological function. Nothing but it causality directly associated with the medicines. And adverse drug event, any untoward medical occurrence that may present during treatment with a pharmaceutical product which does not necessarily have a causal relationship with this treatment. For example, if the patient took antihistamines and it led to the sedation and the patient injured in the accident, it is called as adverse drug event. Okay, did you got my point? And next slide. By this adverse drug reactions to be monitored. Actually, in clinical phase trials, only certain there are some limitations, like only few people are involved in the clinical trials, and children, elderly, pregnancy, and lactation people are excluded in clinical trials. Only limited data is detected, and pre-marketing trials have certain limitations, and rare adverse effect could not be detected over there, and chronic effect is difficult to detect, and clinical trial data are under strictly controlled. There's some confidential will be maintained. And many special groups such as children, elderly, pregnancy, lactations, and existence of other disease or drugs, etc. may not be having exposure in clinical trials. And interpopulation difference, like genetic, like every drug will act different upon the people. So it's not properly explored in the clinical trials. So this pharmacovigilance, so ADR monitoring is important after the drug is marketed, nothing but it is called as post-marketing surveillance. And pharmacovigilance is differentiated into two words, Greek and Latin. Greek, it is nothing but pharmakon, nothing but it is drug, and Latin vigilate, to keep awake or alert, to keep watch upon the drugs. And pharmacovigilance. Pharmacovigilance defines as the science and activities dealing with of adverse drug reactions or any other possible drug-related problems, like detection, assessment, understanding, and prevention of the drug-related problems. This is the definition of the pharmacovigilance. By pharmacovigilance, actually in 1959 to 1961, there is a thalidomide tragedy. For what the thalidomide is used? Thalidomide is used for the for vomitings and nausea in pregnant women patients in the period of 1951 to 1961. There they reported like 4,000 to 10,000 cases of phocomelia, congenital limb defects. So this led to the withdrawal of the drug from the market. So these are the pictures of the phocomelia. For that sake, thalidomide has withdrawn from the market. It is called thalidomide disaster. Since then, our world, they focused upon the adverse drug reaction, and they invented a program called pharmacovigilance. By pharmacovigilance, to recognize a new adverse and serious event of the drug and to collect the data of the incidents, aggravating influences, and safety measures even for recognized effects, to whether the known drugs and also unknown drug effects that to be reported. for the known, by the known areas to be reported, means to calculate the incidence of the known areas, and through evaluation of data to plan the risk minimization strategies, and also to evaluate the risk and benefit ratio of the drugs. And need of pharmacovigilance. As we discussed, there is a insufficient evidence of safety of drugs related to the clinical trials prior to marketing the drug, and there are limited number of patients can be exposed in the clinical trial. So after the drug is marketing, the drug will be worked differently upon the genetic and race. The drug will be worked upon differently in the population. So some rare effects, some unknown areas also will be reported. And ensuring public confidence, like promotional rational use of medications and adherence. What is the history of pharmacovigilance? In India, a formal ADR monitoring system was started in 1986 with 12 regional centers. And in 1997, India became the member of WHO program for international drug monitoring, managed by the Uppsala Monitoring Center, Sweden. At inception, first six regional centers were set up in Mumbai, New Delhi, and Kolkata, and Lucknow, and Pondicherry, and Chandigarh for monitoring ADR in the country. Of these 6 centers, only Mumbai and New Delhi were active, and the remaining they used to not report, and the reporting was very poor. And in November 2004, Government of India has launched National Pharmacovigilance Program with an annual grant of $0.1 million approved for 5 years from World Bank. However, the World Bank funding of this program was ended in mid-2009, and this program was temporarily suspended. And in July 2010, under the Ministry of Health and Family Welfare, a nationwide revised ADR monitoring program was launched and named as Pharmacovigilance Program of India to improve ADR monitoring in the country. Initially, under this national program, this national program was under All Indian Institute of Medical Sciences, AIIMS, New Delhi. AIIMS New Delhi was the National Coordination Center, and in April 2011, it was shifted to the IPC, Indian Pharmacopoeia Commission, Ghaziabad. And what is the mission and vision of PVPI? The purpose of this program is to collect and to collaborate and to analyze the report data and to recommend regular interventions and to safeguard the Indian population and to ensure the risk benefit of the drug. How many ADR monitoring centers are there? Under PVPI, AMC plays a vital role in collection and follow-up of ADR reports from healthcare professionals. First, the PVPI started with 22 ADR monitoring centers across the country in the year 2010, and which has increased to 90 by end of 2012. At present, there are 347 AMC centers under this program and categorized into 4 zones: North, South, and East and West. And by so many areas, due to large number of prescription, like if the people visited to, if people consulted to different doctors, then the prescriptions will be more. And also due to multiple drug therapy like polypharmacy, and also areas increase exponentially with 4 or more medication. As sir discussed, due to drug interactions also adverse drug reactions will be reported, and due to irrational prescribing and and due to medication errors also areas will be reported, and lack of proper system to detect and to monitor. And what are the benefits of ADR reporting? As to assess the safety of drug therapies, especially to the recently approved drugs, and also to the known drugs also, to evaluate the risk-benefit ratio of the drug and to know the incidence of the drug, and also to provide updated drug safety information to the healthcare professionals and to other stakeholders, and to change the leaflet of the medicine, and also to measure the economic impact of ADR prevention. And also to regulatory action on the basis of ADR reports to ensure patient safety, and to, I already discussed, to upgrade the package insert of the medicine, and to market authorization recall. If the drug is having more number of ADRs, and if drug is having serious ADR, the drug will be recalled and will be withdrawn. and also batch recall based on clustering of ADR and changes in classification. For example, over-the-counter to prescription-only medicine. ADR reporting procedure, these are the common questions the public and healthcare professionals ask. Who can report? All the healthcare professionals like doctors, pharmacists, and nursing department, paramedical staff, and also the consumers, patients and consumers, and the other public also can report the ADR. What to report? Any serious ADR or non-serious ADR, mild reaction, or known ADRs or unknown ADRs should be reported. And how to report? Report to nearby AMC, and also report to doctor, and also report, there is a toll-free number, and also have to fill the form, suspected ADR reporting form, and whom to report to all the healthcare professionals. And first we'll see about who can report. All healthcare professionals like clinician, dentist, pharmacists, nurses, and physiotherapists, and consumers and patients also can report. And what to report? All types of suspected adverse drug reactions, known or unknown, serious or non-serious, frequent or rare, and reaction from all types of pharmaceutical products like allopathic drugs, Ayurvedic medications, and due to vaccines, and also due to medical devices, and also due to blood and blood products transfusion. Even platelet transfusion and blood transfusion, some reactions will be occurred. Those reactions also to be reported. How and whom to report? Use the suspected adverse drug reaction reporting form, side effect reporting form. It will be available on the official website on www.ipc.gov.in. You fill the form and you can report to the nearby AMC, and also link for ADR form, and filled ADR form should be submitted to nearby AMC. A reporter can also email the suspected ADR to the following mail IDs: pvpi@ipcindian.net or pvpi.ipcindian@gmail.com. And you can report to the helpline number like 1800180324. It is available to Monday to Friday, 9 AM to 5:30 PM. This helpline number launched in October 2013. And you can report through Android application also. You can find in Play Store ADR PVPI app. And this is the suspected ADR reporting form. And the suspected adverse drug reaction reporting form is divided into 4 sections. First is patient information. These are the four important sections. And also suspected adverse reaction means for what drug the reaction has occurred, suspected medication, and reported details. And mandatory fields are like patient initials. Don't write the patient full name in the suspected ADR form, because the patient may feel like he like to keep it as confidential. So write it in initials. Like for example, Uppu Jhansi Rani means you write in UJR. And age at onset of reaction and reaction terms, date of onset of reaction, suspected medication, and reporter's information, and IP or OP number is also mandatory. And essentially required items like patient initials and age, reaction terms, seriousness, outcome, de-challenge, whether the drug is de-challenged or re-challenged, the details also to be included in the form. And reporter information, like who is reporting, their information also need to be written, and date of report. And we'll see one case study. A 24-year-old male patient, NS, with body weight 65 kg, came to the hospital on 22 November 2020 with the following complaints of fever, rash, all over the body. Lesions started over the front of neck, chest, palms, and soles 3 days after the ingestion of tablet amoxicillin 500 mg BD. For fever, there is no history of similar episodes or allergies. On examination, skin over the abdomen shows lesions, erythematous plaques on palms and soles, hemorrhagic crusting on lips, peeling of skin on front of the chest, mucopurulent discharge from eyelids, thickening of eyelids, redness, and watering of eyes were observed. Dermatologists suspected this condition as Stevens-Jones syndrome due to drug amoxicillin. The administration of amoxicillin was stopped 22/11/2020. Sorry, and he was on IV fluids and injection cefotaxime IV 1 gram BD and injection dexamethasone 4 gram BD. Chlorhexidine mouth gargle. This is the treatment of the reaction. Gargle for ulcer, and moxifloxacin tobramycin eye drops along with sopramycin topical eye application, and the patient recovered after 20 days. And additional information is amoxicillin 500 mg, batch number, expiry date, manufacturer, IP number was given. So in this case, what drug cost what? You can answer it in the chat box. What drug cost what? Okay, tablet amoxicillin induced Stevens-Jones syndrome. This is the case of the amoxicillin induced Stevens-Jones syndrome. We'll fill these are the categories of the form, suspected ADR reporting form. For example, we'll fill the form by this case only. What are the patient initials? NS. And age of the time of the date, and age of the patient to be included here, to be written here, and gender of the patient is written here, and weight of the patient to be written here. For example, in this case, the patient initials are NS, and age is 24, and gender is male, and weight is 65 kgs. That to be written in the patient information. And next, suspected adverse reaction. When the date of when the reaction has occurred. In this case, the reaction has occurred on 20, the date of the reaction to be written, and also date of the recovery. In this case, the patient was recovered after 20 days. Means 20 means on December 12th, the patient has recovered. And onset lag time. Onset lag time means the time gap between the drug intake and the reaction. That is called as onset log time to be written. And describe reaction or problem with treatment details. Like if, for example, here he took amoxicillin, like case narrative, the patient took injection amoxicillin, and he had rashes, and like the Stevens-Jones syndrome should be written over here. And also suspected medication details to be written, like for name, injection amoxicillin, and manufacturer details that are included in the strip of the medications, manufacturer and batch number, and expiry date, dose used and route used, and frequency, like if it taken once in a day or twice in a day, that to be written here. And therapy dates, like date of the drug started and date of the drug stop, and indication for what he has taken the drug, that to be written here. And causality assessment, AMC centers will be doing that. We will be doing causality assessment monthly, twice, or once. It depends upon the number of ADRs. It is done with the committee, causality assessment committee, with 6 members, like 2 are from clinicians and 2 are from pharmacology department, and 1 is pharmacovigilance associate, and 1 is pharmacist. And next is action taken. If the drug is withdrawn, click on drug withdrawn, and if dose increased, click on dose, write as dose increased, and if dose reduced, if the dose was reduced, click on that, and dose not changed, click on the dose not changed. If the action taken not applicable is written only in the drugs if given once, like stat dose or SOS dose, and also mostly in anti-cancer drugs. If the drug is withdrawn or not known, you can tick over in unknown. And re-challenge or reintroduction. If the drug is withdrawn, it is called as de-challenge. If the drug is re-challenged means the point at which the drug is again given to the patient after its previous withdrawal. Make the appropriate option whether the suspected drug reintroduced and reaction occurred or not, or effect unknown. If the reaction appeared after reintroduction, you tick on S. And if the reaction reappeared after reintroduction, if the reaction not appeared after reintroduction, tick on no. And if the effect is unknown, tick on unknown. If the if the drug is challenged, the dose may be reduced or dose may be increased. At that time, you can write the dose, if dose of the drug here. And what are the concomitant medications? Concomitant medication means the drug taken along with the suspected drug. For example, I took, for example, paracetamol induced liver damage. The patient took pantoprazole along with the paracetamol. So here, paracetamol, there you can write the paracetamol drug as a concomitant medication. And also concomitant medical product including self-medication, like if the patient is known case of hypertension, he is using telmisartan. Those medications also written as concomitant medication. Except the suspected drug, all the drugs are called concomitant medical product. And the dose used, dose of the concomitant medication to be written here, and route and frequency and therapy dates, date started and date stopped, and indication of the concomitant drug to be written there. And reported details, like who are reporting the case, whether the consumer or healthcare professional, to be the details to be written here. The details like name and professional address and PIN code and email ID and telephone number, occupation and signature, and date of the report also to be written. And sign and name of the receiver to be written. Signature is also mandatory. And other important sections of ADR reporting form or relevant test. For example, paracetamol induced liver damage. There we have the laboratory test like bilirubin levels and all. So the relevant test to be included. Like the total bilirubin, direct bilirubin, or for example, cyclosporin induced anemia, in that hemoglobin levels to be included. And relevant medical history, if the patient is having past history or any social history like smoking, alcoholic, or is a renal and hepatic dysfunction, or pregnancy, or if any pediatric patient, or is having any physically handicapped, you have to write in the relevant medical or medication history. And also seriousness of the reaction. The reaction is said to be serious only if the death has occurred due to the reaction, or if any congenital anomaly has happened due to the adverse drug reaction, and if any life-threatening condition is happened due to the drug, and also if any required intervention to prevent permanent impairment or damage, or if any hospitalization is happened due to the adverse drug reaction, or if any like prolonged hospitalization is happened due to the adverse drug reaction, or if any disability has happened, or other, like if any treatment is given, that is also coming under the seriousness of the reaction, or non-seriousness reaction, or like mild reactions. And outcome, if the patient is recovered, tick on recovered, and if the patient is still recovering, tick on the recovering, and if the patient is not recovered, tick on the not recovered. If the patient is died due to the adverse drug reaction, tick on the fatal. And if the patient is recovered with the sequel, for example, paracetamol induced liver damage, the patient will be recovered with the sequel. So you have to tick upon the recovered with sequel. And if you don't know about the recovery of the patient, tick on the unknown. And other important sections of ADR reporting form or IPD number of the patient and AMC report number, and also worldwide after entering the after entering the ADR case in the VigiFlow, ICSR in the VigiFlow, that the worldwide unique number will be there. That number should be entered in this column. And another reporting form will be there. It will be, only the healthcare professionals should be used the suspected adverse drug reaction reporting form, and the consumers, there is another different form. Consumers can provide detailed first-hand information about their experience with medicines and how these medicines have affected their life. NCC PVPA launched its first ADR reporting for consumers in August 2014. It is available in languages like English, Hindi, and 9 other regional languages like Gujarati, Kannada, Bengali, Malayalam, Oriya, Tamil, Marathi, and Telugu, and Assamese. If you need the consumer form, you can please ask to nearby AMC. They will give the consumer reporting form. This is the consumer reporting form. And these are the drugs withdrawn due to ADRs, like terifenamide withdrawn due to ventricular arrhythmias, and stilbestrol withdrawn due to carcinogenesis, and clozapine withdrawn due to agranulocytosis, and practicol withdrawn due to acylmucocute syndrome, and nimesulide withdrawn due to liver damage. Nimesulide we can see today in pharmacies also, even though it is withdrawn. We can see in some few pharmacies in India also. But especially in pediatric population, nimesulide is totally withdrawn, and it is contraindicated to give in the pediatric people. Due to liver damage, the nimesulide was withdrawn, and servistatin it is withdrawn due to rhabdomyolysis, and COX-2 inhibitor CVS as cerebrovascular accidents. The COX-2 inhibitors are withdrawn in few of the population. And these are the drug safety alerts from January to August 2021. The drug safety alerts are issued to prevent the adverse drug reaction with the drug and to lessen the risk of the adverse drug reactions. Drug safety alerts are issued. Every month we'll receive drug safety alerts from the Pharmacovigilance program of India. In the month of January 2021, fexofenamide, it is used in the treatment of seasonal allergic rhinitis and chronic idiopathic urticaria. There we found the adverse drug reaction like blurred vision. And in February 2021, due to cefpodoxime used in the treatment like respiratory tract infection for both lower tract infection and upper tract infection, Dress syndrome was identified as an ADR. And another drug, clarithromycin, in February, used to mild to moderate severe infection. Burning sensation ADR was identified. And in March 2021, hydroxyzine, used in the treatment of pruritus, urticaria, and atopic contact dermatosis. For ADR photosensitivity reaction was identified. And in salicylic acid for the treatment of acne vulgaris, photosensitivity reaction was identified. And in the month of April 2021, due to zinc acetate diarrhea, which is used in the adjuvant to ORS, diarrhea was identified as an ADR. And June 2021, due to clobazam used in anxiety or epilepsy, Dress syndrome was identified as an ADR. And baclofen used in the treatment of neuronal spasticity and neuronal spasticity, encephalopathy was identified as an ADR. And in July 2021, due to atrocoxib acute generalized exanthematous pustulosis, it is a due to torsemide Dress syndrome, and due to petapine and valproic acid used in the treatment of seizures, neuropsychotic adverse events like extrapyramidal events were identified. And in August 2021, recent one, sofosbuvir, which is used in the treatment of HIV infection, Stevens-Jones syndrome, ADR was identified. So if any, to lessen the risk of these adverse drug reactions, drug safety alerts were issued. So you have to alert with these drugs. And signal review panel recommendation to CDSCO in the month of Jan to March 2021, like the drug tinidazole, it caused the reaction like fixed drug eruption. The signal review panel recommended to CDSO to change the leaflet and to include the fixed drug eruption in the patient information leaflet. And also drug tramadol, led to adverse drug reaction, urinary retention. Signal review panel recommended to CDSCO to change the patient information leaflet to include the urinary retention as an area of tramadol in patient information leaflet. And these are the new drugs approved in India, like Omident-Pag isopropyl ophthalmic solution, 0.02% for the treatment of glaucoma and ocular hypertension, and Avanafil bulk and Avanfil tablet in the doses of 50 mg, 100 mg, 200 mg for the treatment of erectile dysfunction. These are issued for the healthcare professionals to monitor. These are the new drugs, so we have to monitor about the reactions of the drug. So we have to closely monitor the safety of the above drugs, and if any areas, it should be reported to the PVPI. And how to prevent ADRs. ADR reporting strategies receive a lot of attention, and prevention of ADR is some ADRs are unavoidable. Most of the people will feel embraced to report ADRs. So we have to awareness the people and healthcare professionals for the importance of reporting the ADR. And allergic reactions like dose-related effects and idiosyncrasy and drug interaction prescribing errors all fall in the preventable category. 70 to 80% of ADRs are predictable and preventable as per the 1971 report. Hence, identification and understanding preventable ADRs need attention. And there is a challenge. ADRs and PV still remains as a challenging in clinical and scientific discipline, and we always face it as a challenge, and we always continue to expand its domain due to ever increased number of the medicinal products, and the benefits of drug therapy should always be greater than the risk, and this can be minimized by ensuring good quality, safe, efficacious, and rationally used medicines, and to knowledge and to educate and risk management strategies crucially for preventing or minimize ADRs. We have to take an awareness. We have to awareness the healthcare professionals and as well as patients to report the ADRs. This is the main thing to prevent the ADRs. And also and due to blood, as we already discussed, the blood reactions and while the reactions occur due to the blood transfusion, reactions should be reported. Their Hemovigilance program of India was launched. Hemovigilance program of India was launched by Indian Pharmacopoeia Commission in collaboration with National Institute of Biologics on 10th December 2012 as an integral part of PVPI. To this site, we have to report the transfusion reactions. And also the reactions due to vaccines, we have to report to the AEFI. Adverse event following immunization. It is defined as a medical event that takes place after immunization, causes concern, and is believed to be caused by immunization. Recently, with COVID vaccine, we got many number of ADRs in ESI hospital also, like more than 147 ADRs are reported, and we reported it to AEFI. And meterovigilance, the reactions which are occurred due to the medical devices like some syringes and also cannulas, and if like Holter monitoring. In that case, if reactions are there, we have to report it to the meterovigilance. The purpose of meterovigilance is to study and follow incidents that might result from using medical device, and it enables dangerous device to be withdrawn. If any dangerous is happened to the devices, it will be withdrawn from the market. Like for example, Holter monitoring. If the misreading has happened due to Holter monitoring, it will be withdrawn from the market. Certain batch or company Holter monitoring will be withdrawn from the market. And causality assessment. Causality assessment is defined as the evaluation of the likelihood that a medicine or drug that was a causative agent of an observed reaction. Causality assessment It includes the time relationship of the drug, and if any drugs are causing the reactions, the causality assessment will be defined. We will do a causality assessment with two types of scales, mainly WHO probability scale and Naranjo assessment scale. And how the system works, ADR data flow. First, the information will be coming from the patient to the healthcare professional. If the and the healthcare professional suspect that it may be due to the drug, and it will be reported to the AMC center, and then there the pharmacovigilance associate, they will assess the cases and they will send to the NCC, National Coordination Center, by reporting through the Vigiflow. And in National Coordination Center is the headquarters, and there they will review the panels, they will review the signal panel, and they will visualize and they will upload it to the Upasala Monitoring Center. And in their Upasala Monitoring Center, they will analyze the global individual case safety reports and share the information with global healthcare community. And the activities at ESI Medical College, Hyderabad. Here, the ESIC Medical College, Hyderabad, recognized as AMC in the year Jan 2020. And we reported till now, as far as now, we reported 230 ADRs, more than 230 ADRs. And we reported 147 reaction due to Covishield vaccine. And we recently we expanded our activities with NABH hospital and also peripheral hospital. And we are encouraging the pharmacy colleges like from Pulla Reddy College and Reddy College, Reddy College to report the ADRs. And also we are training and we are training for the clinical pharmacy activities to the pharmacy colleges. Here we already 2 batches has passed. And my main take home message is like, dying from a disease is sometimes unavoidable, but dying from a medicine is unacceptable. Let us join hands to promote patient safety. Thank you. Any doubts? Any questions? You please message it in a chat box.
Thank you, ma'am. Thank you for your valuable presentation. There are few queries from our delegates, ma'am.
Yeah.
One of our delegates, she is asking about how artificial intelligence will place an important role in PV in future.
Artificial intelligence.
Yes, ma'am.
Like already discussed, already I discussed about reporting areas in like through PBPI app and all. Hello, is it audible?
Yes, ma'am. Yes, ma'am. It's audible.
Already discussed to report the PVPI ADR PVPI app.
Okay, ma'am. One of our query, one of our delegate, Neelima, she is asking about what are the commonly used tools in PV.
Commonly used tools are suspected adverse reaction reporting form and also ADR PVPI app. These are the commonly used, and also toll-free number 1800-180-3024. We will mostly use suspected adverse reaction reporting form as a main tool to report ADRs. And also we get a call to the toll-free numbers also from the IPC. If you call to the toll-free number, the information will go to the IPC and it will be shared to the nearby AMCs.
Okay, ma'am. Thank you, ma'am. Thank you very much for your cooperation as well as excellent presentation. I hope all the things will be useful for our delegates.
Okay.
Finally, on the behalf of our management, principal, organizers and delegates, I convey my heartfelt thanks for your excellent presentation, valuable cooperation, and make out this conference successful. And we seek the same cooperation in future also, ma'am. Thank you, ma'am. Thank you very much for your. I'll hand over the session to Archana, ma'am. Thank you, ma'am. All the sessions ends here. So we have conducted the e-poster competition for all the delegates who have registered. So we have received 250 e-posters. In the we are giving for best 3 posters. We are giving cash prize for the first prize. It is of 3,000, and for second prize it is 2,000 rupees, and for third prize it is 1,000 rupees. So the posters we received was screened by our scrutiny committee and selected the best 3 posters. And the first prize goes to Veda Sai Gopalam, PharmD, 50th, Pulla Reddy Institute of Pharmacy, Hyderabad. It is first prize Veda Sai Gopalam, PharmD, Pulla Reddy Institute of Pharmacy. And second prize goes to Abdeli Narha Garbala, Naipur, Hyderabad. Second prize goes to Naipur, Hyderabad. And third prize goes to S. Niveta, M.Pharm, Swami Vivekananda College of Pharmacy, Tamil Nadu. Congratulations to all the winners. Now I request Dr. D.K. Suresh, Professor and Head Department of Pharmacy Practice, to deliver his vote of thanks.
Thank you, madam. Honorable guest speakers, principal, management, and my dear colleagues, a very good afternoon all. Am I audible? Am I audible? Okay. So, first of all, I thankful to the organizers, principal and management for giving me an opportunity to deliver the vote of thanks on behalf of Pulla Reddy Institute of Pharmacy. First of all, I thank to the honorable guest speakers, Dr. P. Karunasri Madam, Dr. Mahid Ali Mirza Sir, and Dr. Jhansi Rani. So all 3 guest speakers, they have given the wonderful talk, discourse, and all the 3 topics are excellent and very informative. All the 3 scientific sessions went very well. So all the speakers, they have highlighted, that is medication errors, then the drug interactions, the pharmacovigilance, and each and every corner they have highlighted, and many things we have not known, or we have less information about the pharmacovigilance, drug interactions, the medication errors. You are all enlightened us, and I'm thankful to you all. Apart from your busy schedule, you have spared your valuable time with us, and definitely these 3 sessions are very much useful to our students and benefited a lot. Thank you very much. I also thankful Dr. A. Ramesh Sir, President IPA Narsapur branch, and the other members of IPA branch for their kind cooperation to conduct this program. I thank to our principal. Always he is encouraging to conduct such activities in the college, and he is giving the constant support in the interest of the academic upliftments, and also in the interest of the students' benefit. See, he always is encouraging us to conduct this type of programs. At the same time, I also thankful to our management for giving the opportunity to organize this program. Now, I extend my vote of thanks to my colleagues who have spared their time. Apart from their busy schedule in the academic activities, they have spared some valuable time with us. Thank you very much. And I'm thankful to all the delegates, participants who have participated in this program. And all the delegates, they are very enthusiastic and very interactive. And my special thanks to those participants who have presented the posters. So as you know, total of some 236 posters we have received. All the posters are very good, very attractive, informative, eye-catching. And really it was a tough task for the scrutiny committee to select the 3 prizes because all are really very good. So my request, my advice is, please you take the printouts and display in the college or in the library so that it will be useful to your juniors or your colleagues also. And I also thankful to the coordinators, Dr. O. Archana and Dr. Sujana Devi Reddy madam. We have taken a lot of pain to organize this program. And we have done the best in best arrangements in a short period of time. I wholeheartedly congratulate you and I thankful to you. And at the same time, I also thankful to our technical support team. They are my colleagues only. Dr. Ravindra Babu and Mr. Imaduddin, Dr. Ravindra Jellu, Dr. Siddhartha, and this computer technician that is Dr. Raju. They have all helped a lot. Because of their support only, we have conducted this program in uninterrupted manner, in a smooth way, very nicely. And finally, I congratulate all the delegates for the active participation. Without your participation, without your support, this program is nothing. Because of your support only, so we have conducted this program in a grand way. Once again, I thankful to the organizers, principal, management for giving me an opportunity to offer the vote of thanks on behalf of entire Pulla Institute of Pharmacy. Thank you. Have a nice day. Thank you.
Thank you, sir. By this, we are ending our webinar. Thank you everyone for joining this webinar and making it successful.
Please make an announcement. The certificates
and the participation certificate as well as e-poster participation certificates will be forwarding to your mails within the week. I repeat, your certificates we will be forwarding to your mails within a week. If you are not receiving, please contact us. And if you are registered also, if you are not sending your mails also, please again send your mails, so that we will be sending your certificates to your mails. We are sending the feedback. Please write your feedbacks in the feedback forms and send it us in the groups. Thank you. Thank you everyone for joining this webinar. Have a nice day.